It is an honor indeed to have you all join us virtually, united in one commitment in improving the health and well-being of our children across Africa. Being that said, my name is Amanda Mbikwana. I'm the Director of Center for Children's Environmental Health of South Africa. Children's environmental health is an underserved area of environmental health. And advocating for the health of our children is an integral function of our center. We are partnered with the University of Zambia. We are partnered with Break the Cycle, an American initiative aimed at highlighting research which break the cycle of children's environmental disparities. Colleagues, this conference is a unique opportunity to address the critical and urgent issue of children's environmental disparities. Our theme highlights the importance of breaking the cycle of inequities that many children face due to environmental factors through research. By coming together like this, we can share knowledge, foster collaboration, and develop innovative solutions to ensure a healthier future for all our children. We are also privileged to have an extraordinary lineup of our keynote speakers who will share their insight and expertise on various aspects of children's environmental health and also share their contribution. I would also like to extend my heartfelt gratitude to our co-hosts, our co-sponsors who are here, and partners. Their dedication to this cause is truly commendable and vital to our collective efforts. To our presenters, thank you. Thank you for your hard work and dedication to research. Your findings and perspective are the heart of this conference, and we are eager to learn from your valuable contributions. Highlight your findings and perspective are the heart of this conference today. I would also like to encourage everyone, our participants, everyone who registered, everyone who's here, to encourage you to take full advantage of the opportunities for this virtual conference offers, to engage in our chat, to engage in our question and answer session. Colleagues, let us leverage this platform to connect, to collaborate, to inspire one another towards this actionable change. Once again, welcome to our first virtual conference, Break the Cycle of Children's Environmental Disparities, Africa. Together, let us embark on a journey of discovery, innovation, and meaningful impact. Thank you, colleagues, and I look forward to a productive and inspiring conference. And I will hand over to my co-host, Dr. Ruben and Dr. Nosuki. Thank you so much, colleagues.
Thank you, Amanda. Nosika, it's all yours.
Thank you. Thank you, and good morning. Good morning, colleagues. Very early in the morning in the US. It's mid-morning here in Africa, depending on where we are. So good morning, everyone. It's such a pleasure to be here. And I cannot re-echo the words of my colleague, Amanda. This has been a long journey, almost 10 years in the making, and even longer if we think about how long Break the Cycle has been in existence. So thank you so much for joining us on this inaugural, the first ever Break the Cycle conference for Africa. And like my colleague Amanda has said, we have an excellent lineup of presentations, of keynote speakers, and just looking at the participants list, I'm also encouraged that we'll probably have a lot of interactions as we go along. So just program-wise, we have, like I said, we have 2 sessions every day. So, and our sessions are diverse, as Africa is diverse. We have diversity in the program in terms of the topics. We have diversity in terms of the presentations as well. You'll notice that we have some research projects. We also have some proposals. We have diversity in terms of the topics. So we're moving from chemical exposures of children to climate change, to food safety, and also to actionable projects on literacy and other inequalities. So Africa is not a country. And as we go through our presentations, we'll be able to see that we're moving from the east to the west, to the south, to the north, and we'll see the depth of what we're doing. But more importantly, at the end of this conference, we'll have to sit and ask ourselves, what next after this? So we're hoping that you'll stay with us throughout the conference. Would encourage you to stay with us. We've made the program very short. It's only about 5 hours every day. So we'll be starting at 10 GMT +2, and then finishing at 3:30 every day for the next 2 days. So please stay with us, and we have a very important closing session where we'll have to map the way forward after this conference. So we're encouraging you to stay with us and just begin this journey with us. To our students who were brave enough to be the first ever to do this conference, we thank you and we look forward to your presentations. To our keynote speakers, we thank you. And to our colleagues our co-collaborators, Break the Cycle Incorporated in the US, it's 4 o'clock in the morning there. We don't take your commitment for granted. Thank you so much for being with us. And we look forward to a very productive and informative conference. Over to you. And just to say, before I hand over to Dr. Rubin, I would like to just sort of introduce him. I'm sure he'll say a few words about himself, and most likely we can read in the booklet. But I just want to thank specifically Dr. Rubin for not giving up on this program. We met 8 years ago at a small retreat in Seattle, and we've been talking ever since. I've been a student, I've been a mentor on the Break the Cycle program. So Leslie, thank you so much for your commitment, and I hand over to you to take us through the first session. Thank you, everyone.
Thank you, Nosika and Amanda, Samantha Langer, and Owen. Thank you all for joining this conference. As Nosika said, she and I met about 8 years ago and started to explore the question of children's environmental health disparities in Africa, and based it on our program called Break the Cycle of Children's Environmental Health Disparities in the US, which started 20 years ago. So on our 20th anniversary, we have this breakthrough session looking at all the health disparities in Africa. And as Nosika also said, Africa is not a country, it's a large continent of many countries, and disparities occur in countries as well as around countries, as well as between countries. And our job as presenters and as the audience is to try to improve the health of all children all over the world so that they can all enjoy healthy lives and productive lives and lives with promising futures. And I think that's our collective goal. I do also want to thank Jimena Guillen, who is our project coordinator, program organizer, and her commitment has been amazing. Without her, this couldn't have happened. And I also want to thank all the other people who participated in our monthly sessions. We've just been going on for quite a long time. This kind of conference doesn't happen from the sky. It happens because of the commitment and dedication of many people. And if you look at the conference booklet, which was put together by Amanda and Samantha and Jimena, I think you will find the richness of the conference, the richness of the projects that you're about to hear from all the students who are participating from, I think, more than half a dozen countries in Africa. And you will look right at the back of the booklet for all the people who have been part of this over the course of preparation. And again, one more comment is that we call it the first annual conference on children's environmental health disparities in Africa, and that's what it is. It's the first annual conference of children's environmental health disparities in Africa. What I'm going to do is I'm going to introduce you to the concept of breaking the cycle of children's environmental health disparities and move you from where you are, wherever you are in the world, to the USA, where I'm currently located. And I'm originally from Johannesburg, South Africa, where I grew up with dramatic disparities, and it sensitized me to looking at disparities in the United States and said, you know what, we cannot let this happen. We all have to roll up our sleeves and see if we can improve the situation for all children all over the world. And I think we'll give that a try at this conference. Again, I'm going to just ask Jimena if you have any housekeeping items you'd like to tell everybody about as they kind of sit through the conference, what they can do, what they can expect, how this is going to look. Jimena?
Absolutely. Thank you, Dr. Rubin, and hello to everyone. Thank you for joining us today. I guess, yeah, a few housekeeping things. Feel free to drop your questions, comments in the chat. Let's keep the chat active. We ask that you stay muted until we get to the question a section at the end of the presentations. But like I said, you're more than welcome to drop your questions in the chat at any time. And yeah, just have fun. We hope you enjoy all of the sessions that we have today. And like Dr. Rubin said, you can find the program and additional details for each presentation in the booklet that we shared with you. Thank you.
Thanks, Jimena. One more dedication of gratitude is to our keynote speakers who have given of their time, their energy, and their expertise to help anchor much of what we're going to hear from these amazing collection of students who responded to our call for papers and research projects. And I have to tell you, the diversity, as Nosiko said, is quite broad, and I think you're going to really appreciate it. As Jimena said, please use the chat to make your comments. They will be recorded, and if we don't come to them, please forgive us, because there may be more than we can come to. The format of this conference is that we'll have the set of speakers. Each of the students will who have prepared projects will give their presentations for 15 minutes. There will be 5 minutes for question and answer. We have breaks in between, and I think you'll find it very informative and hopefully enjoyable, and hopefully more than anything else, inspiring. What we're going to do, we hope that many of the mentors of the students, because each of the students who will present has a mentor in their university who will introduce them, but failing that, if they're not available, I will do the introduction for my particular session that I'm moderating, and then subsequently Nosiko and Amanda will also do the introductions for the students in their particular sessions. So without further ado, I'm going to start my presentation. Jimena, I'll do my slides. Let's have a look. I'm just looking for my slides, everybody, so be patient. Okay, there we go. Sometimes takes a minute or two to get things organized, and let the games begin. There we have the first slide, and as you can see, if you're in this conference, you're familiar with this logo. Just to tell you that we had over 400 registrants from all around the world, and that has exceeded our expectations. We know that on these conferences or these virtual conferences that not everybody who registers actually attends, but it's still good to know that we have so many people interested in this topic. And this is going to be recorded, so it will be available on our website in the near future, and you'll be able to connect with us. If you have any ideas in between, you'll let us know. So here we go. Welcome, the first annual conference on breaking the cycle of children's environmental health disparities in Africa. And what I want to do is give you a little bit of a background. And for those of you who are not familiar with the term health disparities, according to the Healthy People 2030, which is a document that looks at what the needs are of the world population for the next 10 years or so, targeting 2030. By 2030, we will have accomplished so many things in improving the health of people around the world. And what they say about health disparities is these are differences that are linked with social, economic, and or environmental disadvantage. When you talk about disadvantage, you're talking about poverty, and you're talking about limited resources. I also would like to Please, if you would all mute yourselves so that we do not have interruptions. And Jimena, I think you can take responsibility and mute all. And if you can't hear me, just let me know or unmute me. Okay. Now, I'd just like to add one more component. There's another component in here. It says social, economic, and environmental disadvantage. I just want to add that there is a political determinant of health that is very closely linked with all the social, economic, and environmental factors. And it's for those of us who have the passion to influence the political decisions that are made in terms of the health of our populations, particularly our children, and with the health of our environment. I also want to mention in terms of environment that our environment is changing and not for the better. And we're privileged to have two speakers who will be addressing environmental issues and environmental determinants of health in terms of climate change. I particularly feel urgent and anxious and almost desperate to the point that we are now experiencing significant increase in our global temperatures that is affecting people all around the world, heat and dramatic climate events that will be addressed as we go through the conference today. Just looking at what the impact is of disadvantage in terms of health is that determinant of health or that measure of health where you talk about death or mortality. And if we look at what infant mortality is measured by the number of deaths per 1,000 live births of children under the age of 1 year. And in the United States, the average is actually a sum of factors. And this, as in this particular diagram, you'll see that for those mothers who are wealthy, the infant mortality is just over 2 per 1,000 live births, which is about as good as any other country in the world. Whereas the mortality for infants of disadvantaged mothers, and again, disadvantages social, economic, environmental, and political, and is more than double that. So if we look at the disadvantage, we can see that it affects health, but it also ultimately reduces life expectancy. So then we asked, all right, so what is the disadvantage and who are those children who experience disadvantage? And according to a paper in the pediatrics from 2016, and it's old, but it's still relevant, is the children who are poor are those whose parents have less education. And in the United States, those are the ones whose parents may not complete high school. Those parents who are not working full time, so it's education and employment. And for those children who live with single parent families, usually mothers only. So this is the profile of children who are poor. This is the family profile, and we can see this across the world: education, employment, and family integrity. Now, in the United States, the U.S. Census, for those of you who are not aware, has 60% of the population who are classified as white. We have almost 20% who are classified as Hispanic, generally from Latin America, South America. We have a population of people who are classified as Black or of African origin, who came, many of them, most of them involuntarily, through the slave trade of the terrible years between 1600 and 1800, and those who are Native American, who were original indigenous peoples of this country, whose population is less than around 5%. Some say less, some say a little more, some say 3, some say 7, but these are the people who populated the continent, both continents of the Americas, the North and the South. And in the North America continents, the population was estimated originally to have been over 120 million, and now we have only around 5 million. And sadly, that population was decimated, but we're beginning to recognize the power and importance of the indigenous peoples of the continent, and recognize that their children are suffering. And we want to right this. We want to improve the health disparities. Now, this is the population, the census in the United States. Who are the children who are poor? These are the children who are representing the total population of children who are poor in the country. And of the children who are poor, 11% are white. And the numbers are the greatest numbers of children who are poor are white because of the larger number of white population. But representatively, the Hispanic population is poor, or more than 25%, almost 30% of the children who are poor are Hispanic. Over 30% are Black. And as you can see, the population is small, so the representative population of children within that group is tremendous. And the more horrific picture is of children of Native American origin, who represent the smallest population group, but almost the largest group of children who are poor in the United States. If we look at infant mortality, a moment ago, I showed you a graphic of infant mortality in between wealthy and disadvantaged mothers. I will show you now what it looks like between the representatives of the various populations. And as you can see, for the non-Hispanic white, it's 4.6 per thousand live births, which corresponds to many mid-level countries in the world. And the population, the mortality of the non-Hispanic Black, Native American is more than double. And that is like getting to really the poorer groups of people in the world. I ask next the question, where do these children live and how are their environments? And poor children live in older houses in poorer conditions. And for those children, because these houses are old, they're more likely to have been painted with paint containing lead, so they get lead toxicity, and lead causes brain damage. So whatever their disadvantage, they have additional disadvantages in impairment in their cognitive learning function and ultimately compromise their outcome. In addition, they're at twice the risk for developing asthma, breathing problems. And this is because of the environments in which they live are more polluted than they are in the more wealthy environments. And not only are they more than double at risk for asthma, but they're more than 3 times likely to die from asthma. So twice the risk of asthma and 3 times as likely to die from asthma. So you can see how the mortality rate could be affected by that factor. They also live in unsafe neighborhoods, overcrowding, a lot of traffic, litter, food deserts. Food deserts are those areas that have limited access to healthy foods for one reason or another. Also, they have limited access to green space. Green space is those open areas where there's nature, and in this very warming climate that we have, global climate, green space is life. It helps keep things cool. And unfortunately, they're also exposed to crime, more crime. So in this population, more than 60% are likely to be obese. Obese is more than overweight. You're critically overweight, and that's very bad for your health. And also, they're more likely to experience violence. And the reason they're obese is there are multiple reasons, one of which is there's limited areas where they can move around, and if there's crime in the area, they tend to stay at home, watch TV, and because of the food deserts, the access to food is poor quality, so they have high calorie, high salt, high sugar food rather than nutritious food, and they experience violence. Finally, in terms of poor children, is that they go to schools that are old, in poor condition, that have teachers who are poorly paid and who are less motivated, and the buildings are older, and the air in the buildings is less healthy, less clear, and so they don't have as good education. And the sad reality is that 50% less likely to graduate from high school. And as you saw a moment ago, if they don't graduate from high school, they're less likely to get good jobs, and they're less likely to be employed twice as likely to be unemployed, and therefore they don't have good incomes and they don't support families as well. And so we find these are the poor children in those statistics. Now, not only are those important factors, but I want to just present you with all the factors that affect health disparities, just looking at the US, but you can look at it all over the world. We have poverty and racism, which is pervasive. We have stressed mothers who have a difficulty keeping their children together, fed, clothed, sheltered. We have unsafe neighborhoods, which I've just described, which creates stress and insecurity and anxiety, financial insecurity, food insecurity, living insecurity, residential insecurity, and just insecurity for their lives and risks for violence. So they're exposed to more toxins. I told you about the quality of air, the lead in the paint, and various other factors called environmental inequality, and you're going to hear presentations on environmental disparities shortly, and one of our keynote speakers. Their education is limited. They don't have opportunities to further their education and become good wage earners for their families. Climate change is the factor I'm mentioning, and you're going to hear more about it over the next couple of days. And limited access to healthcare. So they may not be as well, but they also don't have as good access to healthcare. These factors will emerge in the discussion I'm going to give you in a moment on how the inequities and disparities in Africa. So I want to introduce you to the cycle of health disparities, which is derived from all the factors I've told you a moment ago. Limited education, limited employment, limited healthcare, limited choices of where they live, food insecurity, income insecurity, limited green space, degraded built environment, climate and violence. And at the bottom, you'll see cumulative impact, chronic stress, which is emotional, which affects health, and also environmental exposures. And it ultimately results in these adverse health outcomes, which you see here in yellow on the side. Mental health disparities of toxic stress, post-traumatic stress, substance abuse, violence, physical health outcomes, asthma, obesity, diabetes, heart disease, developmental disabilities, and pregnancy vulnerability, poor prenatal care, prematurity, low birth weight, intrauterine insults. And the sad reality is this is intergenerational. And the question is, can we make a difference? And the answer is unequivocally, absolutely, we can make a difference. We can make a big difference. All of us can make a difference. And even if we make a small difference, we're making a difference. And all the little differences add up and ultimately make a big difference. So how do we break the cycle of these health disparities? We recruit bright, creative university students to develop projects that break the cycle. The students present their project at a conference, which is you're going to hear about in a moment. They write up their project for publication. They become our future leaders. So the students you're going to hear from today are our future leaders. So pay attention to what they say, to their names, because you will see that they will make a difference in the world in the future. So what have we done so far? I'm going to just give you an example of some of the projects that we've had over the last 2 years here in the US. These are student projects, access to public water and sewer services in some areas, eviction policies during the pandemic, manufacturing sites and the toxins released that are linked to birth defects, socioeconomic modifiers and health outcomes for extreme premature infants, adverse childhood experiences on educational outcomes, lead in private well water and educational outcomes, legacy pesticides and exposure with adverse outcomes to development, community readiness, some strategies to address childhood asthma, and knowledge, improving people's knowledge as a way to end environmental health disparities. And so what we do then is we break the cycle of children's environmental health disparities. And now, 19 years since our first annual program, we've had 19 programs, over 200 students from 54 universities, departments in the US, 22 states in the US, 6 countries in Latin America, 2 countries in Africa, from South Africa and Zambia, and you've heard from Nosiko and Amanda, and we've had publications. All students get their projects published in journals, and this is our very first journal, International Journal of Child and Adolescent Health. And so we've had 16 journals since the start of our project. We also get their papers published in books. This was our very first Break the Cycle of Environmental Health Disparities. We also did one on environmental justice, which you'll hear about, which is addressing environmental inequities. And the last one we did also was on COVID and dramatic disparities. Then we also have done one on climate change and on indigenous populations, which are yet to be published. So then how do we take that and address international aspects of child and environmental health? And we're going to now look at how we break the cycle of children's environmental health disparities in Africa. How do we take what we've accomplished in the last 19 years and translate it into the issues in Africa? I just want to put this in front of you. First, these are the Sustainable Development Goals of the global United Nations, WHO, and they're just going to look at the top line, which says poverty, no hunger, good health and well-being, education for all, and we also need to talk about clean water and sanitation, the work industry, sustainable goals, climate action, and peace, justice, and institutions, and number 17, partnerships for the goals. That's what we're doing here. This is a view of poverty in the world, extreme poverty from last year, and the darker the color, the darker the red, the greater the poverty. Where do you see the greatest poverty in the world? Sadly, we see it in the African continent. And if we translate poverty into infant mortality, as I showed you in the United States, we look at the child mortality rate. And again, you see the darker the red, the greater the mortality, and that those children who, and this is child mortality. I spoke to you a little earlier about infant mortality, which is the number of deaths per 1,000 live births by 1 year of age. And the child mortality is the number of deaths per 1,000 live births to the age of 5. So these are just different measures, but as you can see, children on the African continent are more likely to die before the age of 5 than children on any other continent. If we look at different parts of Africa, different countries, you can see that there are different rates of infant mortality. You remember I showed you that in the US, for the wealthy mothers, it's 2 per 1,000 live births, which is about as good as you can get in any country in the world. And for the disadvantaged mothers, it was around 5. But if you have a look here on the African continent, on the top is the best, which is between 10 per 1,000 live births and 24.9 per 1,000 live births. And as you go down to get more and more red colors, you get to countries where the infant mortality is up to 100 per 1,000 live births and more. That is like 10 times of the poorest children in the United States. So if we have a look at infant and child mortality, this is from the WHO. The WHO says that children in sub-Saharan Africa are more than 14 times more likely to die before the age of 5 than children in developed countries. And as you heard when I quoted the statistics on infant mortality, in the US, it was somewhere around 5 at worst. And here we're talking about over 100 per 1,000 live births. So they're 14 times more likely to die before the age of 5. And many of these early deaths could have been prevented or treated by simple and affordable interventions. And I want to add by prevention. So what we want to look at in this conference over the next 2 days is what can we see about what we can do to prevent and treat children who are suffering and who are likely to die from whatever those environmental factors are. They also say that risk of child dying is highest in the first 28 years of life. The first 28 years of life is where after birth. And also the sad reality is there's also very high maternal mortality. Mothers are much more likely to die in childbirth in the poorer countries, not only in Africa, but also the United States, that the poorer mothers are more likely to die in childbirth, which is just unconscionable. And so it says here, safe and effective neonatal care, and I will say prenatal care is essential to prevent all these deaths. And for the first 5 years of life, the main causes of death in childhood are pneumonia, diarrhea, and malaria. And I just want to say a little about my own experience as a pediatrician in Johannesburg, South Africa, dealing with the inequities and injustices. That deaths from pneumonia and diarrhea were from those children who were poor, those children who had poor nutrition. And as it says in this particular report from World Health Organization, that malnutrition is the underlying contributing factor in about 45% of all childhood deaths, that whatever ailment we might all have, if you're poor, you're undernourished, you're more likely to get sick, you're more likely to die. So nutrition is a critical aspect of infant health. And if we look at nutrition, we can also look at malnutrition. And hunger and malnutrition in Africa is sadly a very big factor in contributing to the infant mortality and the child mortality. And the statistic from African Development Bank group on the left in the numbers, in terms of the numbers and in terms of the representation of the level of food insecurity and food hunger in the Africa. You can see the World Economic Forum, and it says here at least 216 million African children suffer from stunting and malnutrition, which predispose them to illness, which then can cause death. And in sub-Saharan Africa, malnutrition is the second leading cause of death among children after malaria. So in this particular paper in the Journal of Public Health Africa, I had extracted some of the factors that they listed that contributed to infant mortality in Africa. And listen to this: education, adult literacy of 62% is what I was saying about in the United States. It is lack of good education, and it starts right with the kids. Primary school enrollment rate at 71%. So if children don't get a good education from they're very small, they don't read well, they don't learn, and they don't get good jobs, and they can't look after the health of their children. And some of this is the responsibility of governments to pay for education, and some of it is lack of resources and lack of opportunities. In terms of health services, again, as you heard from the World Health Organization, that there's poor quality services around the time of birth. And in this statistic, only 54%, just over half of all births in Africa, are attended by skilled professionals. These are people who look after mothers before they give birth to their infants, to make sure that they're healthy, and look after the children after they're born, to make sure that they survive and they have opportunities for good health. And only 50% of children receive oral rehydration therapy when they have diarrhea. So if they don't receive oral rehydration therapy when they have diarrhea, then they're more likely to die because they're undernourished. Their bodies don't have that same ability to resist the infections and the dehydration. So these are very simple strategies, and the health services are limited, and this is limited at large levels and small levels in access. And if you remembered, I mentioned in terms of the Sustainable Development Goals, it's access to safe, clean drinking water. And in urban areas, access to safe drinking water is only 83%. And access to basic sanitation, 53%. But in rural areas in Africa, access to safe drinking water is only 55%, and basic sanitation, 30%. So you can see, if you do not have clean water and do not have good sewage, then you're going to be more likely to be exposed to infectious agents, bacteria in the water, more likely to get the diarrheal illnesses, more likely to become dehydrated, less likely to receive oral rehydration therapy when you have diarrhea, and more likely to die. So we created the International Cycle of Environmental Health Disparities, which looks at poverty, limited education, limited employment options, limited income. So therefore, they live in poor circumstances, overcrowding, food insecurity, disruption, high unemployment, adverse environmental factors, unsanitary conditions, lack of clean water, adverse social factors. They get exposed to infectious diseases, HIV, AIDS, toxins, and violence, which I haven't yet spoken about. Violence is just a very big factor here in Africa. And the adverse health outcomes of poor prenatal and obstetric care, birth trauma, asphyxia, low birth weight, high maternal and infant mortality, and malnutrition, infectious diseases, untreated conditions, high childhood mortality, mental health of depression, post-traumatic stress, substance abuse, crime and violence, and then this compounding factors just perpetuates the cycle of health disparities. And now I'm going to just give you a glimpse and a taste of what you're going to experience today. These are the projects that the students prepared for you today. Blood levels and risk factors among school children in Lesotho, cook stove technologies for children's safety in Lusaka townships, food safety among food handlers in the Limpopo area, schistosomiasis among children in South Africa, lactation and exposure of human infants to metalloids in sub-Saharan Africa, exposure of environmental hazards and children's undernutrition in Uganda, breaking the cycle of emotional abuse for youth and children in Madagascar, cognitive stimulation among mothers of infants living in Nairobi, Kenya, and climate literacy and children's health in Nigeria. This is just a sample of what you're going to hear today over the next 2 days. And this is where we break the cycle of children's environmental health disparities in Africa. And it's only the beginning. I want to leave you with one thought, that despite even if we make a very small difference, we're going to make a difference in the whole world. There's a saying that if you save the life of a single child, it is as if you're saving the whole world. Thank you very much, everybody. And we'll now move on to our program. What I'm going to do, I think, Jimena, can you put up the next slide of the next speaker, please?
Yes.
Okay, so this is a presentation from Beatrice Mutai from the University of Nairobi. And Beatrice, are you ready to do your presentation?
Yes, I am.
Beatrice, is your mentor available to introduce you?
No, she was not able to join in.
Okay, well then I have the honor of introducing you, and I'm going to introduce Beatrice, who is at the University of Nairobi. Her mentor is Elizabeth Obembo from the University of Nairobi, and also Professor Sarah Benke from the University of Washington. And Beatrice's presentation is on activities among Kenyan mothers that stimulate cognitive and language development in their infants. And without further ado, Beatrice, you're on stage.
Okay, thank you so much for that introduction. Is it okay if I share my slides? Okay. Please let me know if you can see my slides.
Yes, we can.
Okay, thank you. So as you've heard, my name is Beatrice Mutai. I'm a pediatrician and a PhD student at the University of Nairobi. I'm going to present my study results on activities among Kenyan mothers that stimulate cognitive and language development in their infants. My mentors are Professor Obimbo, as you've heard, from University of Nairobi, and Professor Sarah Benke from University of Washington. My slides are not moving. Okay, so by way of introduction, the first year of life characterized by rapid brain growth and increased brain plasticity is an important period in child development. Data from low and middle-income countries, however, demonstrate significant delays in child cognitive development, and approximately 80% of affected children live in sub-Saharan Africa and South Asia. McCoy in his study estimated that 14% of preschool children in these countries fail to achieve basic cognitive milestones, mainly those on paying attention, understanding and following simple instructions, and communication by the age of school entry. So while studies in Africa report low caregiver involvement in infant cognitive stimulation, there is limited data in the Kenyan setting on the extent to which caregivers, especially those who live in urban areas where we have high exposure of children to environmental neurotoxicants, engage in cognitive stimulation activities with their infants. The multiple indicator cluster or mixed questionnaire developed by UNICEF in 1990 provides an easy-to-use, standardized household tool for assessing child cognitive development. It is similar in structure to the demographic or DHS survey tool and has been implemented in over 100 countries. Indicator EC5 in this questionnaire contains 6 questions that assess engagement by household members in cognitive stimulation activities. And under this indicator, caregivers are asked to state whether they or any other household member have participated in the 3 days preceding the survey in either reading child picture books, telling stories, or singing songs with their child, or if they have taken the child outside the home, played with the child, or named, counted, or drawn things with the child. Engagement in 4 or more out of these 6 activities is an indicator of adequate engagement by the caregiver. Just a brief summary of studies that have used the mixed questionnaire. Carter et al. In 2020 found that among mothers of children aged 3 to 4 years across 62 low and middle income countries, only 39% engaged in 4 or more out of the 6 activities, while only 11% of others engaged in the same. Russell et al. In Tanzania found that among caregivers of children aged 18 to 29 months, 93% of mothers engaged in at least one of the stimulation activities, and 48% of others engaged in the same. While ownership of toys in Tanzania was 51%, ownership of at least one child picture book was low at 11%. In Thailand, Topothai found that among mothers of children aged 5 years, 90% of mothers engaged in 4 or more of the 6 stimulation activities. Ownership of at least 3 picture books was at 38%, and ownership of at least 2 toys was high at, I think, 90%. Our study objectives, therefore, were 1, to determine the proportion of mothers at Dandora 2 Health Center in Nairobi engaging in cognitive stimulation activities with their infants, with the hypothesis that less than 40% of our mothers would engage in 4 or more out of the stimulation activities, similar to what was reported by Carter's. 2, to determine the type of cognitive stimulation activities that mothers engaged in. We hypothesized that majority of mothers would engage in playing with and taking the child outside the home, similar to what was reported by Russell in Tanzania. And 3, we wanted to determine maternal household and child cofactors for cognitive stimulation. Our hypothesis was that older maternal age Higher level of maternal education, low birth weight in infants and male sex would be associated with adequate infant cognitive stimulation. This was an observational study where we followed up our prospective birth cohort. We enrolled 400 mothers during pregnancy from the Dandora 2 Health Center and followed up mother-child diets at 6 weeks post-delivery, and then at child ages 6, 12, 18, 24, 30, and 36 months. We selected these time points based on what was logistically possible, based on available resources in terms of time and finances. Data was obtained using the UNICEF Mix questionnaire, and we presented descriptive summary statistics on the proportion of mothers engaging in adequate cognitive stimulation with their infants and types of activities. We are currently in the process of doing logistic regression analysis to determine cofactors. Just to provide a bit of context to the study site, Dandora 2 is a densely populated, low socioeconomic peri-urban settlement. By peri-urban, I mean that this is a settlement that is situated in the outskirts of Nairobi, 13 kilometers from the city center. It is characterized by a mix of high-rise residential buildings together with semi-permanent and temporary structures as shown in the photo that I have put there. It lies adjacent to the largest dam site in Nairobi, which is the Dandora dam site, where we have a lot of indiscriminate garbage disposal and open air burning of garbage. Children living in this environment are constantly exposed to smoke in air and pungent smells. I will now present results from 354 mother-child dyads for whom we currently have complete data at 6 and 12 months post-delivery. So this is still an ongoing study. Starting with baseline characteristics, the median maternal age was 26 years. Majority of mothers were married at 86%. And the median number of years in school was 14 years, corresponding to post-secondary level of education. Majority were homemakers at 54%, and the main support person for 82% was either the husband or boyfriend. The majority of infants were female at 52%, and the median birth weight was 3.2 kilos, which is normal birth weight. Median monthly rent for households was Kenya shillings 3,500, corresponding to $35 US. This is really about the average monthly rent that one would pay at about $30 US in a low socioeconomic settlement in Nairobi, as was reported by Taluk Dar. And the number of rooms per house was 1. Looking at the 6 cognitive stimulation activities that I had earlier talked about, we found that a high proportion of mothers in our study population, at 71%, engaged in 4 or more cognitive stimulation activities. This is higher than the proportion of 39% reported by Qatar's, but it is lower than the 90% reported in Thailand by Topothai. It was interesting in our study population to note that while ownership of manufactured toys was high at 82%, we had very low ownership of child picture books at 11%, similar to what was reported by Russell in Zanzibar, Tanzania. Mothers engaged in 4 main stimulation activities, which were singing songs, telling stories, playing with the child, and taking the child outside the home. And we had more than 70% of mothers reporting that they had engaged in these activities at both 6 and 12 months post-delivery. The most commonly reported activities were playing with the child and taking the child outside the home, similar to what was reported in Tanzania. We had approximately 50% of fathers engaging in the same 4 activities at both 6 and 12 months. And it was interesting to note that while we had between 30 and 50% of other adults in the household engaging in the same 4 activities at 6 months, this proportion decreased to less than 20% at the age of 12 months post-delivery. It was concerning to note that only a very small proportion of any of the household members engaged in either book reading with the infants or naming, counting, and drawing things. Our study findings break the international cycle of environmental health disparities through the identification of gaps in infant cognitive stimulation activities by caregivers living in a peri-urban, low socioeconomic settlement where children are disproportionately exposed to environmental neurotoxicants. Our results also inform targeted strategies to support optimal caregiving within similar settings. In conclusion, we had a high proportion of mothers in Dandora participating in cognitive stimulation activities with their children. And while mothers and other household members mainly participated in singing songs, telling stories, playing and taking children outside the home, book ownership and book reading were uncommon. Our next steps will be to examine for cofactors as well as relation between cognitive stimulation and neurodevelopmental outcomes within this study population. Our study was unique due to our study population, where while previous studies that have looked at this topic have focused on caregivers of older children, mainly 3 to 5 year olds, we focused on infants, so age 12 months and below, which could explain the low book ownership of child picture books. Our limitations included the fact that our study population was derived from this peri-urban, low socioeconomic setting. Therefore, our results may not be generalizable to populations in different settings, such as those of higher socioeconomic class. Our data was also based on caregiver reports, which may be biased due to either over or under reporting. Going forward, we propose an exploratory study to understand caregivers' perception within this study population on the role of book reading in infant development based on our findings of low ownership of child picture books. I wish to acknowledge the entire ABC study team, the team of investigators, as well as the institutions and organizations that have funded this research work. These are the study references that I used. And thank you very much for listening. I am happy to receive any questions or comments. Thank you.
Thank you so much, Beatrice. That was an excellent presentation, wonderful research project and impressive collection of co-workers and acknowledgements, really wonderful. I'm opening the floor for any questions. Anybody have any questions? Please put your question in the chat and we'll get to it. Actually, I'm going to ask you, I mean, first of all, I want to say thank you. That was an excellent project. And I'm sort of particularly taken with your description of the environment that the people live in, not just the poverty, but you described some of the sort of toxic aspects of the environment that were, I'm assuming there were some factories nearby. Can you just clarify that for me, please? Beatrice, if you're talking, you're on mute.
I'm sorry, I lost my connection briefly.
Okay. I'm glad you're
Yeah,
back.
but I can hear now. Yeah.
Did you hear my question, Beatrice?
No, I didn't. Sorry.
Oh, okay. Beatrice, my question, my comment was you described not only the social, economic environment, to some extent the cultural environment, but you also described some environmental toxins, the air quality, and I wondered what kind of factories or industries or kind of chemical contributors to the poor quality of air there were in that environment. Beatrice, are
Okay.
you?
So, yeah,
Okay.
I've had your question. So apart from the downside that I described, where we have a lot of air, open air burning, we do have a few industries there that manufacture things like, I don't know how to describe them. We call them mabatis, like for roofing structures. So the metal roof, that are used for really the temporary housing that you had seen. We also have soap manufacturing industries and a few other manufacturing industries for food products like jam and margarine around that area.
Okay. And my other comment, Beatrice, was, you do look at the importance of books and comment that these are still very young people, but I'm particularly impressed by the fact that the mothers are singing to their children, telling their children stories. I think that is so rich and so enriching for the infants. It creates that relationship with the child. It sort of transmits the sort of primal cultural elements of the particular songs, and it also transmits that connection. Talking and singing with your baby I think is like elemental, and I think that's very powerful. And I don't know if in any of the research that you've examined, there is attribution to those particular activities that mothers engage with their children in.
Yeah, so I do agree, and studies have shown that there is a lot of development or skills that the infants, the children acquire just from telling, listening to the stories, participating in that and singing songs. So things like language development and also good interactions skills, even by the time or the age of school entry. However, based on studies, you still find there's the importance of reading the picture books, because then you have the additional element of eye coordination, looking at the pictures, interpreting the message, and in addition to really what they would benefit from listening to stories and singing songs. So interpreting what is being seen and actually understanding that as a method of communication, and the shared book reading is what is really important with the caregiver.
Wonderful. Thank you for that additional clarification and information. Beatrice, that was fantastic. Thank you so much. And please keep up your good work and don't go away. There's still a lot to come. I'd like to introduce our next speaker, Francesca Rollison, who is she's actually at Brown University in the US, but she's going to be talking about breaking the cycle of emotional abuse for youth and children in Madagascar. Francesca, do you have a mentor present to introduce you? And if not, I think I've just done it. So, are you ready, Francesca?
Yes, I am.
All right, please go ahead, show your slide, and go for it, do your presentation.
All right. Let me just figure out thinking. Hello, everybody. Thank you so much for having me. I'm just going to share my screen real quick. Can you see my screen?
We can.
Yes, we
Yes.
can. And okay. Okay,
Wonderful. You're on.
great. Well, hello, everybody. Thank you so much for the introduction, Dr. Rubin. And thank you, everyone, for having me. It's nice to actually see familiar names and faces in the room. I am Francesca Raoulison, and I'm the founder of the organization Umena. And today I'm going to share with you about the work that we do to break the cycle of emotional abuse for youth and children, to prevent mental health in Madagascar through social emotional learning. And as a trigger warning, this session includes discussions and content related to trauma caused by emotional abuse. So I'll be sharing some examples which might trigger some of you. So please take care during our session if needed. So as background, I am from Madagascar. And Madagascar is the fourth largest island in the world. We are off the coast of Africa, and we are known for our unique fauna and flora. And if you ever get the chance to visit, I definitely recommend you come in. And now I'm going to share a little bit about my story, which ultimately led to the creation of the organization Umena. So this is me when I was 7 years old. And in my early years, I always thought that I was a problem. I was consistently criticized and humiliated by adults and other children around me. And I always felt like I was not enough and that I didn't belong. And the words, and they were not just words, actually, they were echoes in my mind, really shaping my belief about myself and the world. And I experienced this type of trauma called emotional abuse until my early adulthood in all the different settings of my life, in my household, in my romantic relationship and friendships. And that was the little story. And now that I talked about emotional abuse, I'd like to ask you actually, what comes to mind for you when you hear emotional abuse? And if you can, please feel free to drop your responses in the chat, and I'll try to open it and see if you can engage with me. That would be awesome. There's no right or wrong answer. I just would like to know what comes to mind for you when you hear that.
Francesca, just from my point of view, it's
Mhm.
any comment made to a child that makes this child feel anything less than
Mhm.
valued and important. I think that's a kind of general
Mhm. Thank you, Dr.
generalization
Rubin.
that I can think of.
Yes, yes. I do see in the chat distress, anxiety, suppression of emotion. Thank you so much for answering. I appreciate it. Okay, well, let's see. Thank you. So I do see when you are deprived of the right to feel and have your own way of reacting to circumstances, might came across as an emotional like oppression across oppression, and if it persists, it becomes an abuse. Thank you. Instilling fear. Thank you. Thank you, everyone. Well, emotional abuse is a form of psychological abuse. It is also called, it is also called verbal, emotional, or psychological abuse, and it is invisible yet profound. And like shared in the chat, if it's done repeatedly, it can manifest first as belittlement, invalidation of emotions, giving the silent treatment, for example, control, manipulation. It can be called emotional abuse if done repeatedly. And it can happen in any type of relationship, and it is a pattern of destructive behavior that creates invisible wounds, and it is a systemic erosion of self-worth. So to put this into context, in Madagascar, according to UNICEF, there is 84% of children experiencing emotional abuse. That's almost 10 million children, and this number is only the reported cases of emotional abuse. So the actual number might be higher. Emotional abuse is really a cultural norm in Madagascar that has been inherited from systems of oppressions like colonialism and patriarchy. And it is so ingrained that people don't see it as wrong anymore. And that number for me was a wake-up call. And that's what really led me to react. But basically understanding what emotional abuse is was my first eye-opener, but also understanding the consequences of emotional abuse on people's sense of identity, dignity, self-esteem, and especially mental health, because it creates intergenerational trauma, mental health issues, and it prevents people, communities, and countries from reaching their full potential. So in response to this, I shared my story, and I shared about emotional abuse being normalized in Madagascar in a video, and unexpectedly the video went viral. It was shared massively, not only in Madagascar, but in 13 different countries. And that's when I realized that I was not, it was not just my story, and that I was not the only one going through this, and that it echoed the experiences of many others. And that's where I realized as well that emotional abuse is really an invisible global pandemic that we don't talk about enough. And that was the seed from which Umena grew. A community really formed organically, and we've been united by the same mission to break the cycle of emotional abuse and heal. So now I'm gonna tell you more about our mission, which is actually in our name, Umena. So Umena in the entire word is actually a play on words in my native language. In Malagasy, Umena means give, provide, and Mena, the second part, means red. So in this context, we don't have red flags. We use red card as a way to say stop to violence and also as a sign of danger. So through our program, we provide and we teach children and adolescents, young adults, how to spot red flags of violence and abuse, and to really help them foster healthier relationships. So this is our model. We recruit young adults to become community educators. So the young adults are the catalyst of change, and our model has been co-created with them. So they first go through our mental health prevention training, where they learn about the signs, the causes, and the consequences of emotional abuse, and where they receive for 3 days, they receive the social emotional learning tools, which is basically for them to learn about what are emotions, how to identify them, how to express them in healthier ways, and how to nurture, to improve their mental health and to nurture healthier relationships. So they are the future parents, and they're the leaders who will ensure that the cycle of abuse ends with them. And then they go through what we call community of practice for 6 months. So this is a combination of self-help group and support group. It is a safe space where change of behavior and collective healing really happens. And it is where they practice setting boundaries and developing their confidence. They develop also vocabulary around emotional health and self-agency. And they share best practices to validate their emotions as well as others, and where they bring up difficult conversations while keeping each other accountable. And finally, they graduate after 6 months, the ones that have gone through the entire training and community of practice. They become community educators, and they go on and start raising awareness around emotional abuse, because what we realized is that we cannot address an issue that we are not able to recognize. So they help put a word on what emotional abuse, and they go on into the community, and they also promote our social emotional learning curriculum in schools for 10 months. So this second part is done in private schools, in 5 different schools, but here I am gonna focus more on the program that we provide with youth, the young adults. Now this is our theory of change. This is our theory of change, which is basically the outcome and impact is for a stronger emotional health and well-being. Here you can see our output for each of our activities that I mentioned earlier. But overall, as a byproduct, we want happier, healthier, and more productive youth leaders, making a positive change in themselves first, in their relationships, society, communities, and in the country. And that's where actually throughout this logic model that we can see also the systemic change that is happening, the change of behavior. And that's also how we break the intergenerational cycle of trauma caused by emotional abuse, by having better mental health outcomes and social and economic outcomes, by breaking the cycle of poverty, by breaking the mental barriers that is keeping them from not reaching their full potential and not flourishing. And we do that through our emotional education and the youth empowerment training that we provide. So concretely, for the past 5 years, our approach has reached over 5,000 students through our 250 community educators that have graduated. And all of them recommended our program, and 98% of them acknowledged that Umena has been the most transformative experiences of their lives when people don't know, first of all, what emotional abuse is, and there is no space where they can share that and where they can't really feel safe to do so and feel acknowledged and validated in their experiences. That's where Umena comes in and provide that safe space and that psychosocial support for those going through this experience that makes it transformative, because research shows that even having one person where you can confide and have that safe person can dramatically change your mental health. Now, here are some of the behavioral changes that we have been able to measure in our educators over the past 4 years. We have been able to follow them throughout the year, and we could see their improvement on their emotional regulation, on how they have been fostering healthy relationships, setting boundaries, making decisions now, and use healthy coping tools. And along with this number, we have one case study that is from one other educators. Her name is Fanil, and she says, "Thanks to Umena, I've been able to change the way I perceive the world around me. I've grown mentally, and I have noticed that I'm starting to get rid of my toxic habits. By helping myself, I've been able to help others better understand their difficult times. However, even though I have achieved many positive things, I cannot deny that I still have a lot to reconcile, especially in my relationships." So intergenerational trauma is very hard to heal, but healing is possible. It is not linear. And this is an example of how some of our educators have been able to go through the healing process while still really acknowledging their wins in how they are managing themselves and their relationships, but also realizing that it is not linear, and there's still a lot of I would say self-help work to do, but also in the dynamics that she has in the other relationships in her lives. So now, in terms of our strengths and limitations, Umena has been recognized as the only youth-led organization addressing emotional abuse using social emotional learning approach in Madagascar. And as a result, because this has been such a new concept, people have been very receptive. As a result, we have seen really significant demand for our training, and our waiting list continues to grow. But unfortunately, we don't have enough resources and capacity to keep up with this demand. We have also been able to leverage the power of digitalization to expand our impact and reach, because we have been sharing our training online. We have shared that every Monday, basically on social media, and also from sharing the personal stories from our educators. We have grown from having a single voice to over 50,000 followers across all of our platforms. In terms of also limitation, we are currently seeking grants to properly conduct our research and publish it really nationally, but also internationally, not only to add more credibility to our work, but also to continue raising awareness around what emotional abuse is, because research really shows that before escalating into violent physical abuse, it usually starts with subtle emotional and verbal abuse. So we want to shed light on this issue so that people can start seeing the signs before it escalates into potentially violent abuse. In terms of suggestions, we've been working on our internal processes a lot to carry our growth, and we are open for suggestions from other experts in the field, but also we're exploring partnership with other organizations in Madagascar, in Africa, interested in incorporating our mental health prevention approach into their models, because again, we know that emotional abuse is a global health issue, and we also welcome, again, your feedback in the work that we do. So thank you so much. Thank you, Break the Cycle, for giving us the opportunity to raise awareness around the issue and for amplifying our work today. And a shout out to my mentor, Bill Allen, for his continued support, as well as my team at Umena for the engagement to our cause. And thank you everyone for having me today. So I'm open to any of your questions, and here are some of the references that I use. And yes, thank you.
Thank you so much, Francesca. Excellent presentation, inspiring, innovative, creative, born out of your own personal experience as a child, and now influencing thousands of people in Madagascar and around the world. And I just wish you continued success. A wonderful example of breaking the cycle of health disparities and intergenerational trauma. I open the floor for any questions for Francesca.
Thank you so much. I'm going to stop sharing, and in case, unless you want me to go back to my slides, please feel free.
Kind of nice to see the picture of everyone, but that's okay.
Okay.
I just want to say one other thing, Francesca. You comment about connecting this internationally. You're doing this in this particular forum, but also, as I mentioned, with our Break the Cycle health disparities in the US, we publish every year all the student presentations. Our plan is to publish as many of the presentations that are given today as possible, and it depends on the particular presenter's interest in writing up your paper for publication, and we have a contract with the publisher to publish it in an international journal, as well as in a book. So that opportunity is now open to you. So thank you again for introducing us to the concept of emotional abuse and how powerful it is as a sort of on physical and emotional health of children, and how powerful it is to try to interrupt it. We still have a couple of minutes for questions.
Can I come in?
Please.
Dr. Ruben?
Yes.
Oh, okay. Thank you so much. Thank you so much, Francis, for this is a powerful presentation. The work that you are doing is not just emotional, it also touches the aspect of spiritual. And I mean, breaking the intergenerational trauma. It's a very deep thing. There's a wise word that says that we must guard our heart, because out of it flows the boundaries and the issues of life. So imagine somebody who has been through that, they are unable to live to their full potential because of what they've kept and stored inside of them for many years. So my question is, it's more on the parents, because there is no one who will just wake up and start emotionally abusing somebody verbally or projecting. They usually, parents, we usually project what we've been through verbally to our children without us dealing with the issues that are in us and we've experienced throughout the years while we're growing up. So it always goes back to homes, what we experience at home, we also take it to other kids, verbally abusing them anyway, because it's what is in us. So I just want to find out, with regards to parents, are you maybe conducting workshops on parents as well, or training them, something like that? Thank you.
Thank you. That is such an important question. So just a little bit of background as well. So I experienced it mainly at home. That's how I really realized it. And I remember back then I shared a video with my dad, a video that talked about emotional abuse, and I shared it with him one day. That was maybe 7 years ago. And he looked at it and I was like, "What do you think about this, Dad?" And he said, "This is wrong." And I was like, "Okay, but do you know you're doing this to us, Dad?" And he lashed out. He was like, "What you talking about? I don't do that." And of course, I ended the conversation there. But a month later, he came back to my mom, my brothers, and I, and he apologized. And he said, "You're right. I do this. And my dad did the same thing." And that's where all of the things that I was reading about intergenerational cycle of violence, but also about not being aware of even recognizing that we have done it because we don't have the name for it. So that's what we have seen for most of our educators so far. When they realize about it, and sometimes they bring it up with their parents. Some of the parents are open to the conversation. Some of them are in denial. Some of them never have the hard conversation, but that's what we have almost all experienced as community educators joining Omena. And what we have done in the past, because we thought actually that it was easier to address the issue with young adults and youth, because they are still, first of all, we can meet them where they are, which is in school. And it was easier for us to go there and to have the partnership with the schools. But for parents, because we thought the assumption was that they are very busy to make ends meet, because again, like in a lot of African country, we live with under $1 a day. It's very hard for parents to have the time to go to the school and to be part and to engage with those in those type of conversations. But the more we have been vocal about the work that we have done, that can be on social media, that can be through conferences, by training the different kids, we have had parents actually starting to be curious about what we do. And we have been running few focus groups where we have had the same approach that I have with my dad. We showed them a short clip where the definition was there, because we also, in terms of culture, we didn't want to be the ones as the young generation to be the one telling them about what emotional abuse is, because also we wanted to respect and also not put the finger on them, but more coming from a place of empathy, showing that this has been an heritage really of systems of oppressions. Like I said, in the case of Madagascar, the colonialism has been one of them, that it has been ingrained, and that's how it has been passed down as well, the way that people back then have been talking to the people in Madagascar, and how it has been ingrained. And having them recognize that, and having them actually in the focus group, we realized that after we shared the video, it became like a therapy session for the parents. We had 15 parents in the group, and they started opening up, and they would say, I experienced this in school with one of my French professor back then, and now I'm talking like this to my child sometimes. So we had those very powerful conversations and healing journey as well, that started through those very hard conversations, but also very enlightening for the parents who were part of the conversation. And it's definitely something that we want to continue, but we're trying to find a way to have more parents. Thank you.
Thank you, Francesca. That was excellent. Appreciate your introducing us to the so many aspects of what you just said, and I can only say to be continued. We now have just a few more minutes until the next presentation. For the next 3 minutes, just entertain yourselves. The next speaker will be Napo Julius Mola Clearly, and he will be talking about blood lead levels, and this is a little change of pace from the emotional discussion we've just had. So let's just take a little break. We will start at 35 minutes after the hour, another 3 minutes. So we'll just be quiet for just a minute. Thank you, Francesca, again, and we look forward to hearing more of your work.
Thank you, everyone, and thank you for having me. I'll put my information in the chat if you'd like to connect, or if you'd like to reach out or ask more questions. Thank you.
And your website will be great.
Yes, I just did as well.
May you go from strength to strength.
Amen. Thank you.
And we now have Napo Julius Mola-Clearly, who is from the University of Johannesburg. We'll be talking about assessment of blood lead levels and risk factors among primary school children in Maseru district, Lesotho. Napo, you have the stage.
Thank you, sir. Could I just quickly share my slide for everyone?
Yeah, go ahead.
Yeah. Okay. Just quickly. All right. Can anyone see the slides as they appear?
Very well, thank you.
Okay. Greetings, ladies and gentlemen. This is Napo Mola-Clearly said from the University of Johannesburg, and I'll be presenting my research entitled Assessment of Blood Lead Levels and its risk factors amongst primary school children in Maseru District, Lesotho. So first of all, I just want to go through the background of lead and everything. So what is lead? So I'll definitely start with what is lead in the environment, or lead as in general. So according to Igbogon et al. In 2023, he says that lead is a natural occurring heavy metal that is toxic and can be found in many sources or many products, consumer products. And it continues to say that due to its unique characteristics that allow ranges or wide range of uses, such as production of water pipes, lead has been, or it has been found in the environment through anthropogenic activities. So we can conclude that lead can be found in the environment naturally as well as through anthropogenic activities. So now that we see that lead can be found through anthropogenic activities, what are sources of lead in the environment? We found that lead can be found in the environment through soil or paint and water, as well as maybe food that we eat. So according to Checkwest and Beckstead, they reported that, sorry for that. Can I take a break? Thank you. I was just rushing. They reported that paint and petrol still remain a significant source of lead in the environment. So now that we find sources of environment sources of lead in the environment, what are the routes of exposure in children, or how do we absorb this lead how the children absorb this lead in their body? So it is said that they can absorb this lead through inhalation and ingestion of it. So children have hand-to-mouth behavior, which allows them to ingest lead, and well as inhaling it in the air. So what are the effects of this lead once it's absorbed in the body of a child? So it has been told that lead reduces the IQ of a child, as well as decreasing the metabolism in children, as well as their growth. So what we do once we find these effects of lead in the environment, so CDC updated the reference level in 2021, where they said the level, any lead level about 3.5 microgram per deciliter need medication attention, or we can say any level that is below 3.5, it's not safe, but it's still within manageable range. That's the background. So where was this study done? It was done in Maseru District in Lesotho, which is a very landlocked country within South Africa. So the main reason that we chose Maseru District, it is because it is an industrialized area in Lesotho, where we have many industries within the area, and failure to control our waste is one of the reasons to choose the district. So as we can derive from any explanation that has been said before, the hypothesis in the study was that there are high blood lead levels amongst primary school children in Maseru District, Lesotho. And what we can say over is that soil samples in the study from children's homes and schools had high concentration lead levels. So what the methods that were used in the study, we took an analytical approach to achieve our aims and objectives. So first of all, what we did is to gather our information. We had questionnaire, which was sent as a package, take-home questionnaire to parents and guardians of children. So what the questionnaire included was section A, which was the demographic information of a child, which was more about sex and an age of a child. And the background, which was section B of our questionnaire, included more of where does the child live, and if they have any exposure around their homes of sources of lead, such as waste and everything. And most importantly, which was section C, was the health and the diet of a kid. Here, what we wanted to know was if the kid, how often do they eat balanced diet in a week, maybe twice or once. And then also we wanted to know if they are taking any medication at the moment. So lastly, which was our section D, included the housing location of the house, whether it's rented or owned, and how far is it from sources of lead such as waste and pollution and all of those. and continuation of our methods was that what we did to measure lead in water, we used analyzed hand fluorimeter, which gave us the lead concentration in water. And what happened here with that, because of failure or to evenly distribute our samples within 10 schools that were used, because each school, explaining this thorough so that it can be understandable why our samples were not evenly distributed. Certain schools had different or several water sources, which were maybe, if I clarified further, in a school we had water sources which were 2 or 3 in a certain school, and the other school we had about 2. That says we could only take water samples from a certain school, about 2, and the other school we had to take 1. So any level that was above 0.01 milligram per kilogram were regarded as abnormal in the study. And the second instrument that was used was thermoscientific Newton X-ray fluorescent, which was used to measure lead in soil actually. So the good thing about here is that the samples were evenly distributed per school. So we concentrated, or we took lead concentrations from children's playground actually, or the entrance at school. So 3 samples from each school. In general, there were 30 samples. Any amount of lead that was above 7 parts per million or mg per kg were regarded high in the study. And then what we did was to fingerprint blood lead sampling from participants, and we heard 178 children that participated in the study, and of age group from 6 to 12 years, of which included about 123 girls and 55 boys in the study. And we worked with a trained nurse to bring blood from children. So as I'll move on to the results of the study, as it can be seen here, we had blood levels in children as demonstrated by the figure here. On our y-axis, we have the number of children, and on our y-axis, we have blood levels in children, which were measured in microgram per deciliter. So just to give a brief description of the figure here, it says about 50 children, as the longest bar here on the picture, about 50 children had blood levels between 3.5 and 4. And about 20 of them had blood levels between 4 and 4.5 microgram per deciliter. And the interesting part, we had about 2 children with only blood levels be above 10 microgram per deciliter. So to break it down, we had blood level distribution. That says out of the population that was studied in the study, 98 of them had blood levels that were below the reference level, which was 3.5 microgram per deciliter, and about 44.9% of the children had blood levels above 3.5 microgram per deciliter, which is 80 of them in the study. So as well as we measured the concentrations of lead in water and soil, we had soil being had a low limit of detection in other samples of soil, and the other one had 280.24. So as we can see, our mean is 64.29. What you can see is that other places had very high lead concentrations and others had very low, which was even below limit of detection. And as in water, it was evenly distributed or close by in competition, because as we can see, there was low and the highest range was 6.44. And then the mean was 4.69. That was our lead concentrations in water as well. So what we did here was to use our questionnaire, which was a sent home that was answered by parents and guardians. So what we can tell, or what we can say from the result as shown below, is that mothers play a very important role in a kid's health. So what we can say is that mothers with primary education or highest education has been primary, because of lack of knowledge on hazards and all toxin that affects child's health, shows that mothers with a primary education had their kids having high chances of having blood lead levels. And it's, even though it has not been proven or has not been more literature on the case of heating, in this case, we found that using paraffin in this case, which was a dirty fuel, had high chances of a kid using paraffin at home, had high chances of experiencing blood lead levels in their body. And when renovating, the kids that showed that at their homes had renovation in the past month or a year, had high chances of experiencing high blood lead levels in their body due to the use of decorative paints and all those sort of things. As we can see through that adjusted ratio or risk ratio was 4.40 and all. So discussing our results is that the study finds or supports the evidence that in developing countries, there's still high blood levels due to lack of regulation initiatives to control exposure in vulnerable groups. Maybe if I can explain that in a study that was done in South Africa by Matthew et al. In 2013, reported that amongst primary school children in fishing communities had 74% of those children had high blood lead levels, as well as the study conducted in the same country in 2020 by Cindy et al. Reported about 44.4% of children had high blood lead levels in the body, even though the age group was younger because it was a year to 6 years old. We can as well say that the results from this study indicated that there's lead concentration in the environment, which could be to various reasons, like saying failure to control waste and mining industries within the area, or as well as many industrial industries, more textile industries are located in Maseru district. So moving on, our household renovations have been associated with elevated blood levels in the study. So this could be to the use of decorative paints in our homes and everything. So they could lead, actually the children could experience blood lead levels due to paint that is being used. So how does this project break the cycle? So what we can say from this cycle is that awareness campaigns and education sessions can be held by environmental health practitioners for children at schools, and as well as parents or guardians at communities, and teach them about the toxin that we're experiencing, which is lead in this case, that says a social and economic level. What can also, it can be used by policymakers as a reference in Lesotho to say that we still have high lead levels and how do we regulate it and to amend our policies. It can as well as be used to justify the increased funding to facilitate access to blood testing and treatments, so to reduce the health effects of lead in the environment as well as in children. We can as well as inform the renovation practices, which can break the cycle at environmental, because the toxin that is released in the environment won't be, because people will be informed about the practice, so we can use unleaded paint and all those as unleaded petrol as well. Thank you. So the strength and limitations of the study. This is the first report on blood levels in children aged 6 to 12 years in Lesotho that says there's more, there's evidence that has been proven that indeed in Lesotho, we still have lead exposure that children are exposed to. And as well, the study can be used as a protection or as guidance in protecting children against lead exposure, where you can say we can use proper waste management so that the kids cannot be exposed to lead, and as well as our limitations in this study. There were no funds to expand our study. Only the study limited on or worked with a certain number of schools, which is 10. So we still have numerous schools that we could not approach. And in this study, we only included school children, not like any boy or any kid who doesn't attend school, because in Lesotho we still have those, even though the number is not high, we still have those children who do not attend school. But in this case, that says we could not work with them, and we still have to reach those kids. So suggestions for the future, we can conduct comparative studies with other districts in Lesotho or neighboring countries to understand regional variations to lead exposure and its effects. What we can do, we can investigate a specific environmental contributing to exposure in Maseru districts, such as closeness to the industries and housing conditions. In conclusion, we can conclude that primary school children in Maseru district are experiencing high lead levels in drinking water and soil samples. Sorry. Dr. Leslie, sorry for that interruption.
Yes.
We can as well, I saw a hand from Dr.
Nosiko Munyinda, Nosiko, do you have a comment?
No. It's no. After he finishes.
All right.
Okay.
Julius, yeah, finish your presentation.
But something also revealed, we can also say that the study revealed that the high lead levels in children, which place them at risk. Enclosure.
Yeah, don't worry, complete your presentation and then we'll go to questions after.
So I just want to acknowledge and appreciate the chance to present my study from BTC Africa program, and as well as my supervisor. And most importantly, I just want to be grateful to the Almighty God to give me wisdom and everything throughout the study. Thank you, everyone, and I appreciate the questions and comments there and there.
Thank you, Julius. Excellent presentation. Thank you for bringing to our attention the issue of lead, which is a very serious toxin in children, affects the brain function and learning potential and futures. Nosiko, you had a question for Julius?
Yeah, yes, Leslie, and once again, thanks for that presentation, Julius, and the study. A lot of work went into that. Well done. I have a question and also just a contribution. Firstly, Julius, I just wanted to find out, does Lesotho have the standards on lead in paint yet? Have they developed any standards on lead in paint? I noticed that you found significant associations between the blood lead levels and renovations in the homes. So how far has the country gone in developing regulations on lead in paint? I don't know if you know. And then you also asked about diet for the children. Did you find any relationship between the children's diets and their blood lead levels? I could have missed that in your presentation. Thank you.
Thank you, ma'am. What I can say in the study is that in Lesotho, most of the things are regulations. We don't have regulations concerning lead on exposure in children. So I think the study will work on addressing those kind of policymakers will be aware of such. I hope that question is answered. And as well as the study, children's diet didn't play a major part in blood levels. So I hope I answered your question, ma'am.
Yes, perfectly. Thank you.
Thank you, ma'am. Thank you. Thank you. Any questions?
Julius?
There was one in the chat.
Yes, there's a question in the chat.
Okay, let's see the question. Julius, the question is, if you measured abnormal lead levels in water and soil, did you communicate that to the school authorities?
What we did was to, since we have not gone back to them, we wanted to go back to them and give them the final report of everything. But what I can say right now is that since the study was still underway, was just completed recently, we'll go communicate with the authorities at school, principals and all those people. If I got the question right.
Nomfundo, has your question been answered?
Yes, thank you.
We have time for one more question. Again, thank you, Julius, for bringing up the issues of lead in our environment and how potentially toxic it is to children, and we need to be aware of it, and particularly in schools where children learn and how it affects their learning. Thank you, Julius. You can take your slide down now. And
thank you.
Just to tell everybody that this is our opportunity now for our keynote speaker, Dr. Carity L. Wright, who is the Chief Special Scientist, Environment and Health Research Unit at the South African Medical Research Council. And she's been gracious enough to present her work to us as our first keynote speaker of the day. Carity, you're now on stage.
Thank you, Leslie, and hello to everyone. It's phenomenal to see such a large turnout for today. So I will share my screen, and if I can do that, which I don't think I can. Oh, I can. Share, and then if someone could just let me know that the slides are in presentation mode.
Not yet. There you go. Presentation.
Excellent. Brilliant. Thank you so much for the opportunity to be a part of this really very exciting event. I've never seen such commitment to supporting young people from both the mentors as well as a faculty perspective. It's hugely impressive, and I'm very grateful that I could be here with you today. So I'm a Chief Specialist Scientist at the Medical Research Council, leading the Climate Change and Human Health Research Program. And today I'd like to talk a bit about work that's ongoing within our program. So to start off, it's really important to understand that climate change is real. There are a number of drivers that are influencing the Earth that we experience today, from dust and storm impacts to maternal and child health effects, floods, heat, infectious disease because of changes in environmental conditions, wildfires, which we're seeing around the world, and more. And each of these are associated with health outcomes. And these are extensive. And I haven't got an exhaustive list here. This is something that I think will need more work over time. This is just really the beginning of what we are starting to understand. What I would like to focus on today are the heat-related impacts. These include heat stress and exhaustion and stroke, increased risk of mortality associated with pre-existing health conditions, dehydration, heat exhaustion and stress that can lead to damage of the brain, kidneys, and liver. And of course, because we are talking about children, I'd like to focus in on children. Just to put the context in place of what we know, so we have medium to high confidence that the temperatures are changing in our part of the world. So this comes from the Intergovernmental Panel on Climate Change, their assessment report 6, chapter 9, which is the Africa chapter. And it brings together a lot of information of the climate drivers, what we know about them in the different regions of Africa. And these drivers are drivers of impacts that are of climatic origin that are affecting either an element of society or ecosystems. And the blue arrow indicates the East Southern Africa region, where we are, or at least I am, in Gauteng in South Africa. And if we move along to those first two red squares, they are relating to mean air temperature and extreme heat. And those black dots are telling us that these conditions have already emerged in the historical period. In other words, from the past, we have observed these changes. And the red tells us that we have high confidence of an increase. So this is really bringing together all of the global evidence to say that we are seeing warmer temperatures in most parts of Africa based on observed data. So the work that I'm sharing with you today is still in preparation. It is a review on the impact of rising ambient temperatures on the physical and mental health of children, focusing on low and middle income countries. And we've considered the risks to children's physical health, in addition to their mental health and well-being, associated with exposure to heat. And possible actions to prevent or reduce these adverse health outcomes have also been suggested. So some of the problems that we are seeing as a result of heat exposure among children, I've mentioned before, stroke, dehydration. I don't know why it's there twice. I think it should be stress. Children are more sensitive to extreme heat than adults due to in part that they have a lower ability to regulate their body temperature, and they also have a higher body surface area to mass ratio due to their size that can cause pronounced heat absorption and dissipation. And the risk of mortality in children increases significantly during heat waves. And these direct effects of heat frequently show a marked increase in the prevalence of renal and respiratory diseases, electrolyte imbalance, and fever. And if anyone wants these full references, I'm happy to share them with you. Kidney disease and renal failure is also a challenge. Exertional heat stroke particularly during physical activity. So something we're seeing more and more, that schools are not taking into consideration when we do have heat wave conditions, that sport and outdoor activities should actually be restricted. They should not go ahead. And we have a lot of work to do in this area to raise awareness and ensure that schools, possibly through government policy, are made aware of when conditions are extreme. Children should not be taking part in outdoor physical activities. Data from high-income countries, we have less from low and middle-income countries, shows increased evidence of hospital admissions among children for renal dysfunction during high temperatures. And then there's an example below, children aged 5 to 14 years in Adelaide, Australia. There was a rise in visits to the emergency rooms and increased hospital admissions almost 3 times above normal due to renal dysfunction. And this was in their 2008 heat waves, and they defined a heat wave as 35 degrees Celsius or more for 3 or more days. This is another challenge that we face globally. Definition of a heat wave changes between countries and sometimes even within countries. There isn't a standardized way of defining it, and we are going to have to think about this on a global scale. Then we've also seen a relationship between temperature change and respiratory illness. So in the winter season, we know when it's colder, we see an increase in respiratory diseases, but in actual fact, elevated ambient temperatures can also cause negative impacts on child health. One of these is around allergens, air spora, and pollens that can increase during warmer weather and obviously have allergic reactions on children. Then the study in Vietnam showed that a 1 degree Celsius rise led to almost 4% increase in the risk of hospitalization due to an infection, respiratory infection, and a 20% increase in the risk of admission. And this was for children under 5 years of age. And then similarly, in Alaska, there was a significant increase in emergency room visits, but this is for children under 15 years, after 2 consecutive days of temperatures exceeding the summer average of 21, which does seem quite cool. But remember, relative to whatever their winter temperature was, that is probably quite warm for people who are, and I can't think of the word right now, acclimatized to specific temperatures. Then we are concerned about things like malaria and dengue fever, which are appearing in areas where they didn't exist before or were eliminated. And some of these met factors are known to influence the vector life cycle. So in other words, at the particular stage of a life cycle, if the conditions are just right, you may end up with way more vectors than normally would have occurred, say, in a drought or a flood conditions. And we are using this type of information, particularly for malaria, to project outbreaks of these diseases. Just to share a success story is in Limpopo province, the Limpopo government works very closely with researchers to using a model to be able to forecast the potential malaria prevalence in Limpopo province. And they used this information a few years ago to actually bring the start of the spraying season earlier, and they were able to see a reduction in malaria prevalence because of that change. So there are several studies that have shown that we're going to see an additional number of months per year when malaria transmission will occur, and same for dengue fever. And these are projections for the future based on the historical period of 1970 to about 2000. And this risk is not just for people of all ages, but especially for children. Professor Rubin has already spoken about food security and nutrition, so I won't go through it in detail, except that extreme heat has indirect effects on these health outcomes. It can be associated with respiratory illness induced by thermal conditions or vector-borne diseases and food insecurity. But the real challenge here is that the food production and crop yields can sometimes go down when conditions are very hot, or if there's been insufficient rain or there's drought. And therefore less food produced or less quality food produced is highly likely to lead to undernutrition and other really challenging conditions that we see in Africa, stunting and wasting especially. And the other one, of course, is breastfeeding, which we know is essential for children or infants. And then the psychological impacts of heat exposure, there are multiple effects, even though this is a relatively new area of research. I would say that it is evolving. A few studies have looked at the increased ambient heat on mental well-being of children and neurological effects during heat wave events. But there are some. This one at the bottom here, the first bit was around heat-related morbidities in New York City. But then there was a 17% increase in the mental health issues of children between the ages of 6 and 17 years of age. And some of these issues are related to eco-anxiety. When you realize the world is warming and you're very hot at the time, it does make you start to think, is this what it's going to be like always? So anxiety, as well as depression, when you really have no way of cooling. And then there are unfortunate cases where we are starting to see increase in suicides during very high weather, heat conditions. And of course, interpersonal violence. So increased ambient temperature has been associated with increase in violent behaviors. In fact, we did a study using crime data and ambient temperature in Khayelitsha and saw an association between increased violence during warmer weather. This particular study looked at 9 to 18-year-olds, and they were comparing externalizing behaviors, so aggression and delinquency, with ambient temperatures, and they significantly increased with rising temperatures. I forget where that study is now, but I can look if someone wants to know. And interestingly, these types of behaviors were less in areas with green space. Could be due to a reduction in heat or having shaded areas and a place to go, which was cooler, but it could also speak to some confounding factors. For example, greener areas might be more wealthier suburbs, for example. So we've got to be careful when we analyze these types of data. And then finally, sleep. Heat and sleep is a huge challenge. I'm sure many of us have experienced being extremely hot, not having fans or air conditioning, and it's almost suffocating. So there is a connection between insomnia and mental disorders. And because sleep plays such a crucial role in growth, cognitive function, and emotional well-being, this is a serious concern for us going into the future. If we're wanting productive workforce and children who are able to learn, so we are going to have to manage how best to create the space for people to get good and decent sleep. And in infants and children, the challenge here is this distal skin temperature is a significant determinant in promoting the initiation and sustenance of sleep. This is why babies like to be all nestled up and warm when they're sleeping. Obviously, that's when it's cold. When it's hot, that's not necessarily the case. And this is something that is worrying me in South Africa and other countries in Africa and around the world. In fact, mothers tend to swaddle their babies very tightly in multiple blankets, including during heat wave events. And we've seen this up in Limpopo province. And unfortunately, there have been situations where the baby passed away because of basically overheating, not being able to maintain their body temperature. And the other concern is around stress due to lack of sleep, and this we know has multiple adverse health impacts and mental consequences. So just to bring it all together before I close, is that if we think about addressing these challenges, these climate change challenges with health relevant solutions, there are a number of options for us to be able to ensure that we get a safe, healthy world where people can thrive. So, for example, in the first column, and I won't go through all of them, thinking about adaptation and resilience. How can we build people's adaptive capacity to be able to live through and still thrive in very hot weather. We can do things like encourage greater political ambition, create tools and finance and coordination of various activities to support practical adaptation and resilience. And in doing so, we would be able to build a climate resilient health system and support adaptation. And we have to think beyond just the health sector. We need this in food, water, sanitation, transport, and energy. The other one that I'll highlight here, because it cross-cuts across all of these: energy transition, clean transport, and basically having an ecosystem that is alive and can support us, is the finance. And we know that investing in climate resilient health systems is costly. It also requires political will and people understanding the value health gains that we can achieve from things like carbon mitigation, adaptation policies, and bigger things like fossil fuel subsidy reform and carbon pricing. So some of the ideas that we've come up with so far in terms of a response to these heat health challenges for children, both for mental and for physical well-being, are around health care system access, making sure that there are healthcare services available for children within the sphere of influence of a child's actual living area, not having to spend 2 hours walking with somebody to a clinic in 35 degrees Celsius. We also think there should be pediatric specific guidelines to prevent and diagnose and manage heat-related illnesses in children. There's scope for things like telehealth and remote monitoring technologies during heat waves, especially in our rural areas. And then if we think about the provision of training to our professionals, we probably need to think about more targeted training for heat-related illnesses in children. While there's a lot of work done around children who unfortunately are left in cars in hot weather, or not even in hot weather, who are left in cars that their windows are all up and unfortunately do not survive, there's less around ambient heat exposure and what this means for children living, daily lives. Of course, we also need to think about children with physical disabilities and children in environments where they really rely on carers to try and keep them cool. And we think that we should try and focus and recognize critical symptoms of physical and mental health so that we can include these in the medical curriculum going forward. In terms of community education, there's a lot that we can do. The National Department of Health is already circulating to all environmental health practitioners well in advance of what we anticipate to be the start of the heatwave season in September in Pretoria, information on the heat-related illnesses and how to stay safe in heat waves. And this is the kind of information that should also be incorporated into the school curriculums. We need to advocate at the school level, obviously with provincial support, for cool spaces and hydration. It's not acceptable that for example, in a school in King Williamstown in the Eastern Cape, there's a single tap from which all children at the school, of which there are a couple of hundred, have to try and go and hold their hand under to drink water because they don't have cups and they don't have water bottles. We are going to see more negative impacts on health if that's the situation that we leave children in. And of course, we need to try and come up with coping skills and resilience building strategies to help children manage these psychological impacts of heat stress, particularly, for example, in hot weather for matrics, writing their exams, their final exams, without fans, late at nights when the heat doesn't relent. Green spaces are a great option, of course. They can mitigate heat impacts by providing shade. There's also clear evidence that if there is a tree-lined street versus a street that has not got any trees, the tree-lined street is much cooler than the street without trees. Challenges around green space are difficult as adaptation measures, particularly around heat. In one study that I read, there was an intervention to increase a really large green space in a particular area. And unfortunately, the green space was not actually then used as it should be, but it essentially became a place for homeless people to make a safe space in which to live. The community that had received the green space were very frustrated. So you've really got to think carefully about these things and avoid any maladaptation. And of course, community engagement and fostering these connections are all really critical when we try to do good in such an initiative such as Green Space. And this is the last slide. So from a research perspective, there's much that we can do to better understand heat health impacts on physical and mental health of children. Of course, we need more epidemiological studies. We need to think about ways of best assessing children's heat exposure levels. There's some really interesting work being done where people swallow a small device and measure body temperature as well as wearing an outside logger or sensor to get a good understanding of how the body is mitigating the impact of heat and whether it's doing it well or not. We clearly need to think about intervention studies to try and help protect people from heat, and then, of course, assess them, how effective they are. And it's really important to engage communities in any of this kind of work. And then lastly, we have to take steps to involve our public health units to implement these strategies, especially during warmer seasons. It's going to take a huge collaboration between different organizations. From a heat perspective, we need the likes of our South African Weather Service to align with our departments of health, departments of environment, to really come together and give comprehensive information to the public in the best way we can to help prevent what we saw, for example. I guess we should add the Labour Department, where we saw in January 2 years ago the death of 7 table grape farm workers in the Northern Cape linked to heat stroke. And that is something we don't want to see again. So we really do need to help employers also understand the risks to their employees. I've already mentioned about schools, the work that we need to do there. And of course, we have to think about controlling infectious diseases and probably ramping up these types of surveillance as well as immunization or vaccination campaigns. So in conclusion, I think that addressing the direct and indirect effects is essential to ensure long-term well-being of children worldwide. And we are seeing an increase in ambient heat impacts on children's mental well-being, but it is limited in its research, especially in low and middle-income countries. And we hope that there will be more done in that space. Interventions, green space, and other things, cooling centers, public libraries that have fans or ways of cooling people in the alleviation of impacts of extreme heat are all things that we should try and be striving for. I've already mentioned what the research needs to do, but probably just to add that we have to think about vulnerable groups. We really need to understand the risks and think of the best strategy to protect. And in all of this, we cannot do it alone as researchers. We have to think about engaging our communities and our professionals to make sure that all of these strategies are practical and successful in the end. Thank you very much for listening.
Thank you so much, Carity. And one of the unfortunate things about these virtual conferences is that you cannot hear an applause. Please know that the applause is there. Thank you so much for sharing your time and your experience and expertise and perspectives and suggestions and ideas. Fantastic. From my point of view, every day I look at the temperature in Atlanta, Georgia, and the temperature is consistently greater than 5 degrees above average. 5 degrees above average is pretty scary. And here's another concern, and I don't know if you didn't address this because you only looked at the heat aspect, but in the southeastern United States where I live, there's a big worry about hurricane season. And one of the big issues is that the ocean around the Caribbean, the temperature is 5 degrees above where it has been. And we've just seen the largest, most severe, earliest hurricane that has come through the southeastern United States, even reached the southwestern part Those are big, scary issues. Any comment from me? This is my question before we go on, about what, from your international perspective, you see governments, universities, agencies doing about trying to reduce the rate of climate change we're seeing now.
Is that the question to me?
It is, unfortunately. I mean, I know it's difficult.
I was
yeah.
yeah. So I mean, there's lots of initiatives, as one would understand, that, you know, because heat is such a pressing issue. The Global Heat Health Information Network, or GIN, is an example of a body that's trying to bring together information to support the likes of the United Nations, the World Health Organization, World Meteorological Organization, to get the best evidence, or the best available evidence that we have, put it together into a succinct form so that we can both provide the sort of policy recommendations, but also the information that we should put into the hands of people who need to know what to do practically. So the professionals or healthcare providers, our environmental health practitioners, people who are really engaging with communities. So yeah, I don't think there's any large body around the world that doesn't have heat somewhere on its agenda.
Thank you, Karidi. In the chat, there's a question from Nosiku Munyinda. She said, I'm wondering, first of all, she says it's a very timely research area. I am wondering how it affects pregnant women and resulting birth outcomes.
Yeah. So thank you for that. That is definitely a area of research. There is less work done in South Africa, or potentially low and middle income countries, compared to other countries in the world. The classic example, which you will, I'm sure, understand quickly, is that the initial work around temperature and pregnant women was women who took very hot baths or had used jacuzzis. And unfortunately, there were adverse birth outcomes. And now we're starting to see, there's evidence now of an association between mothers who are pregnant, experiencing extreme heat, and the impacts on the developing fetus. And there are health impacts. And there are a number of groups around the world who are working on this topic. And there's a group at WITS who have been doing, the University of Witwatersrand in South Africa, but there are many around the world. And I agree, I think this is an area that does need more research.
Thanks, Karidi, for the answer to that. There was a comment that the London mayor wants to charge people who pave their gardens because it contributes to heating, urban heating.
Yeah, that's right. And all of these hard surfaces contribute towards what's called the heat island effect. So there's almost a bubble of heat that is persists over big cities because of surfaces that absorb heat or reflect light or the radiation, solar radiation, and move heat in different ways. I'm curious. I like the London idea, the London example, because it reminds me there was a very large building that was built in London several years ago, and just the shape of its design led to the sunlight being directed onto cars, and the cars actually melted. And I remember seeing somebody fry an egg on a bonnet because the light from the building had gone onto the car. And unfortunately, yeah, they had to rethink how that building was functioning in the city. But clearly, building design, urban design, has to take into consideration temperature.
Yeah, that's a very big issue. The urban heat islands. Actually, one of our Break the Cycle students last year had a presentation on urban heat islands among native indigenous populations in the Midwest. So it really is everywhere. Any other questions for Dr. Wright while she's still here with us. I almost don't want you to go now, Carity, because this is really I'm sorry for the pun, but it's a really hot topic.
It is a hot topic. No, you're right. I see there's a comment in the chat about whether there's work being done on heat in Madagascar. I do know that there is definitely work being done in that part of the world, if not by local researchers, but definitely large projects that incorporate projections for climate change, including temperature change in across all of Africa. So that would include Madagascar. And yeah, definitely there's a need for community adaptive capacity building and resilience in countries like Madagascar and other island states.
I'm just going to you're talking about the heat impact on children, on physical and mental health. There's also the indirect effect on, and you touched on this briefly, but on crops and cultivation, resulting in reduced crops, cultivation, starvation, those kinds of things, and food insecurity. And I know our colleague Michael Rudolph will be talking about that tomorrow. But I wonder if you could just touch on that briefly.
Yeah, so in countries like South Africa and others, many children get one meal a day, and often that meal is at school as part of the school feeding programs. And I'm in awe of those programs, and they are essential, but I'm very concerned that we need to make sure that the food that those children are receiving, if it is the one decent meal that they get in a day, is quality food. And the change in temperature, change in water availability, challenges to quality of food, as well as obviously quantity, are concerning. The other is around wash. So the water and sanitation and hygiene type of concerns that we have. Was in the Eastern Cape, working with schools. We were looking at the impact of heat on absenteeism among school children. And the children, before they had their meal of the day, every child washed their hands in the same basin, and it was about 200 children. And that's not optimal. The transmission of basically germs from one child to all of the other children, is a stark reminder of why we actually need to have decent conditions for washing hands and toilets. So yeah, I'm very worried about, and I realize that this is also a bit of a developmental challenge, but most of the climate change and health issues are. And that's why there can be synergy between ensuring that we've got this development perspective, but at the same time factoring in these climatic changes that are going to really affect any development changes if we don't consider them.
Well, thank you. There's one more comment. It said, I wonder, is there work that was done before on cultural and environmental factors that affect children's exposure and adaptation to heat stress in Africa?
That's such an interesting, yeah, that is such an interesting question. So definitely environmental factors. Yes, there has been work done looking at environmental health as well as environmental factors. But cultural, I don't think so. I think that's a really interesting question and probably a research gap.
Thank you, Carity. Thank you so much for your time, your insights, your ideas. And now we have a research gap, so one of the students will have to take that on as a project for next year.
Excellent.
Thank you so much, and I wish you a pleasant day. And I'm sorry we won't have you with us for the next couple of sessions, but appreciate your being here for now. This is our lunch break for those of you who for whom it's lunchtime. And for those of us on the other side of the world, it's breakfast time. So we'll see each other at the half hour, and for 12:30 for the people in the South Africa meantime, and for those of us in the US, we'll wait. This is our lunch break. We'll see each other at 1 p.m. the African time, and 7 a.m. Atlanta time, and I don't know what other times they are. Thank you all for being here. Please continue to put your comments in the chat, because that will be saved. We'll try and answer them later. Stay tuned for the next session, which will begin on the hour, in a half an hour, and have a good break, and be ready for the next session, which will be led by Nosiko Munyinda. See you soon. Bye.
Good afternoon, everyone. Good afternoon, everyone. Imena, can we start?
Yes, go ahead, Nosiko. Sorry, it took me a second to find the unmute.
It's okay. It's okay. Good afternoon, everyone. Good morning again, our colleagues in the Northern Hemisphere. I hope you've had your breakfast. We've had our lunch. So we continue with our conference. We're on session 2. And in this session, we're focusing on environmental justice and children's health disparities. I must make special mention. I've noticed that my mentor is in the conference. Professor Michelo, you're very welcome. Thank you for joining us. And please just keep checking the chats for those of you that have to fill in the Google document, especially our South African delegates, for your HPC accreditation. Please just keep checking the chats for any messages that you might want to see from there. So without further ado, we'll start with this session, and we'll start with a recorded message, a recorded presentation from myself. My internet is not very stable, so we have a pre-recorded presentation, and thereafter we'll go into the student presentations and our keynote address for today. So handing over to you, Imana. Thank you.
Okay, I'm gonna get it started. Please let me know if you can hear the audio.
Cannot hear the audio, Jimena.
Is the audio audible?
No, not yet.
Okay. My name is Dr. Nosiko Munyinda. It's a
Good
pleasure
now.
to be here
Good now.
and
Okay,
to
thank you.
Jimena, it's no longer audible.
So I'm from the
One second, let me
University
get
of
it
Zambia School
started
of
again.
Public Health. And
It seems to come and go.
Okay, let's try again. There we go. It's getting started.
hello, good afternoon, everyone. Good afternoon for those of us this side of the world. Good morning for our colleagues in the Northern Hemisphere. My name is Dr. Nosiko Munyinda. It's a pleasure for me to be here and to present some selected case studies for environmental health challenges here in Zambia, and hopefully it will be the same across other places in Africa. So I'm from the University of Zambia School of Public Health and the Department of Environmental Health. So to start with, I'll start with this quote. 1 in 5 children under the age of 5 in Zambia is infected with malaria. Very alarming. And we have a quote from Rachel Carson from the Silent Spring that, as you can see from the picture there, that one of the most alarming aspects of chemical pollution of water is the fact that in a river or lake or a reservoir or in a glass of water, served at your dinner table, you have mingled chemicals that no responsible scientist would combine in their own lab, but somehow they end up on our tables. So I'll walk you through 3 case studies. I've just selected 3 case studies of some work that we've done in our school. And this is work that's been done on lead poisoning, climate variability and energy crisis, and on the malaria dilemma. We were talking about present benefits versus discounted costs. So the first case study on lead poisoning, we made it to the top 10 as a country. And unfortunately, not for the right reasons. Zambia has a town called Kabwe, which has been ranked among the top 10 polluted cities by the Blacksmith Institute. And why is that so? Is because of the legacy of lead poisoning that has been found in Kabwe, in both the soils, water, and as we will see from the study, also in human matrices. So this study that I'm starting with, we aimed to quantify blood lead levels and study neurodevelopment outcomes in children of selected communities of Kabwe. And just for those that need a bit of reminding, lead is a heavy metal. It's a bluish gray in color. It occurs naturally. Nobody sits in the lab to manufacture lead. And because of its density, it's widely used in a lot of applications. So you find lead in paint, you find it in dust and soil, water. It has a lot of industrial uses, also used in hobbies and traditional ethnic remedies. And now we're finding lead in personal care products as well, lipsticks, nail polishes, and so on. So as you can see there, we have lead almost everywhere. And we focus specifically on children because they are more vulnerable to exposure than adults. And I'm sure by now we've seen why children are a focus for what we're doing here and why they're more vulnerable to adults. Our study focused on those areas, 6 different areas that are close to the mining area. So if you can see here, if you can see my pointer, the mine areas around this Makululu region here. And we looked at areas that were close to the mine, but also a bit further away from the mine. And like I said, lead is absorbed in place of calcium in our bodies, and children absorb up to 50% more lead than adults. And this absorption increases during pregnancy. So you also have a transplacental transfer of the lead. And after the child is born, you have the lead going to the child through breastfeeding and also through other environmental pathways. So what were our results? We found blood lead levels between 0 and 381.6 decibels, or 0.6 micrograms per deciliter. And this is against a WHO and CDC guideline limit of 5 micrograms per deciliter. So you can see that this is almost 150 times more than the set limit. And when we looked at the areas, again, like I showed on the map, you find that the areas that are close to the mine, Choa, Kasanda, Makululu, have much, much higher blood lead levels. And I'm sure, as you can see also from this graph that we have here, the mother's blood lead levels and the child blood lead levels were positively correlated, and the differences among the areas were strongly, significantly different as well. So just to make sense very quickly of those results, we can see here on this continuum of effects that we have, that effects of lead poisoning begin to show in children from as little as 5 micrograms per deciliter. And that's where you start having IQ losses, hearing, growth impairments, developmental toxicity develops around 12, and so on, up to about 140 micrograms per deciliter, where you find death occurring. And just to remind you that we had children that had levels as high as 381 in the sample that we looked at. So you can make your own inferences from there. When we looked at the neurodevelopmental outcomes, we found that, again, we had children having lower scores below the cutoff point for gross motor, for fine motor, followed by problem solving. And as you can imagine, this would affect a child's ability to learn, even if we didn't do IQ testing. And we did the neurodevelopmental assessments using the ages and stages questionnaires. Qualitatively, we also asked for the caregivers' concerns, and we had a myriad of concerns ranging from losses of appetite, hearing complications, the child's weight being low, delayed speech, children lacking interaction with others, and so on, delays in walking. And you can see that these effects that the caregivers were giving us sort of correlate with what we saw in literature on the continuum of effects. We looked at how these neurodevelopmental scores also were affected by maternal characteristics, and we found that mother's educational level, the mother's length of stay in the town, and the mother's frequenting the mining area and pregnancy complications were strongly associated with the child's neurodevelopmental scores. We go to the next case study on energy crisis, climate variability, climate change. And just from these pictures, I'm sure we can see what's happening in a lot of households in Africa. Currently, some places in Africa had massive droughts. So we've had a lot of load shedding as long as 10 hours without electricity in some areas. So people are resorting to using all kinds of fuel for domestic use. And just from the picture again, you can see the smoke that's coming from there. You can see this child on the mother's back, sleeping innocently and inhaling everything that's coming to them through that smoke. So our objectives for this study were to assess the various energy options and reported associated health outcomes for residents of a township in Lusaka called Matero. And we measured indoor air quality variables. We looked at oxygen, carbon monoxide, volatile organic compounds, and particulate matters. So what did we find? As expected, we found that more than almost 95% of the people used charcoal for fuel, for cooking, and a few used electricity. And it was a bit surprising to find that in an urban town, there were people that were still using crop residues, and some were using cow dung for fuel. The pollutant levels, again, we can see from this graph that we had very high levels of volatile organic compounds, high levels of carbon monoxide, and PM10. So these were found to be very high in these households when you compare to the WHO limits. So carbon monoxide, for example, WHO limit is at 10, and we were finding 32 in the households that were using charcoal. Volatile organic compounds had the highest level, as we can see from this graph. We can see for PM 2.5 as well. And like I said, even for PM10, the levels were higher than the WHO limits. And we can see what this means in terms of health outcomes and using the air quality index. So the higher the concentrations, the more unhealthy that actually the pollutant is to human health. We also asked in this study qualitatively what were their reported we also asked what the reported health outcomes were. And as you can see here, we had health outcomes that ranged from coughing, sneezing, chest pain, swollen eyes, shortness of breath, and unconsciousness, dizziness, fatigue. So there were quite a number of health effects that were reported by the households. And when we stratified the results, we found that the households that were using wooden pellets, surprisingly, had higher percentages of reported respiratory conditions, and also people that cooked indoors with closed windows also had a higher prevalence of respiratory conditions. So in this case, obviously, then this is now an issue of housing and the design of the houses and the ventilation in those houses as well. We move to our third and last case study on malaria. And just by way of background, like I said, malaria is still among the top 10 leading causes of death and hospital admissions in Zambia and pretty much most of sub-Saharan Africa. And mostly affected are pregnant women and children. And our Ministry of Health is implementing an integrated vector management strategy, which includes indoor residual spraying with DDT, among other chemicals. So we have IRS that still uses DDT among other chemicals. And so we aimed in this study to quantify DDT exposure and study neurodevelopmental outcomes in children of selected communities in Zambia. For those of us, again, by way of background, DDT is a persistent organic pollutant with lipophilic magnification and accumulation properties, and it was banned. It has been banned in the developed world since the 1970s, and in the year 2000, it was listed under the Stockholm Convention for elimination, except in cases where it's used for malaria control in countries like Zambia, South Africa, and a few other countries in Africa that are still using DDT. So we measured DDT in soil and water, and we did find very high levels of DDT in both the soils and water of the communities that we measured. When we did the community survey, we also found that the type of houses were actually associated with the amount of pests that were in those houses, and so the use of the chemicals. We also found that the houses where the DDT was sprayed or where the chemicals were in use had both pregnant women and children under 5. So this was an interesting finding. And we did ask, you can see the percentages there. So all the households where the spraying was done had both pregnant women and children under 5. When we associated the DDT levels and neurodevelopmental domains in those communities, we found strong negative correlations. So that means that the higher the DDT level, the lower the neurodevelopmental scores in gross motor and personal social domains. As we could see from the studies on lead and the studies on the energy crisis as well, similar with DDT exposure, we still found significant associations, both positive and negative, between maternal characteristics and the children's neurodevelopmental scores. For the mother's age, we found that for communication, for example, the older the mother, the better the child was able to communicate. So now I'll just go through a series of pictures just for us to, those of you that haven't been to Africa, just to visualize some of the places that we're talking about when we look at environmental health disparities in children. So this is not how most of it is, but I think so that we can get the picture. Okay, so we still have a number of environmental emergencies, from spillages of chemicals. We still use the road transport for a lot of transportation of goods. Zambia, for example, is landlocked. We have 8 neighbors. So this is a situation that you find at a lot of our border stations, the stationary trucks, and you can imagine the situation in terms of environmental health in those places. We still have some places where wastewater is used for irrigation, and we can see from that graph there that this wastewater still has bacteriological contamination, and yet we're still using it on vegetables in some places. And of course, the issue of floods, like I mentioned, climate variability. We've seen a lot of countries within Africa experiencing floods. The just ended floods in Kenya. Countries like mine have droughts. Other countries have too much rainfall. And these are the results of those floods. You can see those children, that's probably their school that's totally submerged. They can't have access to their houses. And you can imagine in terms of drinking water as well. A lot of our children spend more than 12 hours playing outside, just outside in the environment. And if the soil is contaminated, if the water is contaminated, then the pathways for exposure are also very, very high. We have a lot of shared water points in our communities, as you can see from that picture. So having presented all this, is it all doom and gloom? Are we here to just exchange negative scenarios? I think this is why we're having this conference, to try and look at alternative futures for Africa, using Break the Cycle, for example, as a vehicle. What kind of future do we see for our continent in terms of children's environmental health and eliminating those disparities that we've talked about? I think for me personally, these are my personal reflections. We need to change how we do science to start with. We need to move from a laboratory setting, very pristine setting where everything is at same temperature and pressure, totally controlled. We have to translate the knowledge that we have, the innovations that we have, into packaged information and actions that will meet various societal and ecosystem needs. We know from the cycle that we've been looking at from Dr. Rubin's presentation, and I'm sure from all the presentations that we hear from the students, that there are so many different factors to consider when we look at a child. When we look at children's health, there's pollution, there's the work environment of the parents, there's the home environment, there's diets, there's other diseases. So we need to put all this into consideration when we're talking about changing the horizon or changing the future. And of course, we have to look at local solutions. We have to go out there and find solutions that will meet local needs. We have to be pragmatic enough to go into some places that we don't normally go into. The picture you're seeing there is of a village in Western Province called Mabumbu. You can see it's a very, very sandy area, and you walk, no car can pass after some point. So you have to walk long distances to actually get into some of these communities. So we have to think beyond just getting international awards. It's nice to get international awards, to meet friends internationally, but more importantly, we have to find local solutions. We have to find answers that will answer the needs of this child here. Ultimately, this is what we're here for, is to try and find solutions that will take care of this baby that's looking for water, clean water to drink. So I'd like to acknowledge various people, organizations that were part of the work that we've been doing as a school, as a community. And just to end by saying, we do not inherit the earth from our ancestors, we borrow it from our children. And this is a Native American proverb. Thank you very much for your attention. Asante sana. Thank you, Nkosi and Zikomo Kwambiri. I will not take any questions because I don't want to preempt what the students will be presenting. But in case you still have some questions you want to discuss, we can always find time, and you can always get my contact details and we can discuss further. Thank you so much for your attention once again. Okay.
Thank you, Nosiko.
Yeah, thank you. Thanks, Imena, for pre-recording. As you can see, as you could hear, we had a bit of trouble when pre-recording, but I'm glad that we were able to get the gist of the presentation. I've seen that there are some questions in the chat. Samantha, you've asked a question about whether DDT is sprayed also in schools and creches, and to the best of my knowledge, no. We have, in Zambia at least, we've managed to restrict DDT to only those areas where there's been recorded insecticide resistance, and it's only sprayed indoors in the homes. So it is only sprayed in the homes indoors. And for the last 3 years, we've had varying degrees of the use of DDT, but I know that in South Africa, it's still being used. And I think it's also still being used in parts of Mozambique as well, within the region. I don't know if there are any other concerns. We can still chat even tomorrow or afterwards, but if there are no more questions, I think we can go straight into our student presentations. And to start us off our presentations, we have
Nosiko, sorry, I have a question for you just before we go on to the next one. It was an interesting...
Okay, please go ahead, Leslie.
Yeah, there was an interesting juxtaposition in your in the beginning of your presentation with the comment that malaria is sort of one of the major causes of death for children. In fact, it's very prominent. And if we heard Carrie right earlier today, the likelihood is that malaria is going to get worse as the temperatures rise. And then you spoke about the Silent Spring and Rachel Carson's comments in the water, and it's interesting that the DDT is the agent that helps to destroy the malaria vector. So that's quite an interesting challenge we have to balance, which is the to killing the malaria vector, the mosquito, with the toxin that potentially cause harm to children. I wonder what thoughts you have. I'm not saying there's an easy answer, and I think obviously we have to kind of be very thoughtful in our approach, but I wonder what you might, comments you might have on that.
Yeah, that's the dilemma. That's the dilemma, Leslie, of the present benefits versus the costs. We do know that DDT has, it does work. It has a very long residual effect compared to the other chemicals, and it's still relatively cheaper than the other chemicals that are used for malaria, for mosquito control. But at the same time, we also know that in the long run, there are effects that DDT has. They have been proved in other settings, and we're seeing, even from our limited studies, that we do have DDT in our environment, and it could be contributing to some of the neurodevelopmental effects that we're seeing in the children that we studied. So it's a matter of, it's a balance. And just to say that the Stockholm Convention hasn't given an open-ended exception for the use of DDT. At some point, even the countries that are using it for malaria control will have to stop using it. And right now, I think it's only being manufactured in India. And I've been told that the manufacture there is also going down. So whether we like it or not, we have to start phasing off the use of DDT even within Africa. So we have to start looking at alternatives very, very actively and see what could work in place of DDT, or even more, just look at larval source management, see how we can manage to control the proliferation of the vectors of the mosquitoes outside of the home. So there are efforts in Zambia and within the region to look for alternatives, Leslie, to try and phase out the use of DDT. But it is a dilemma. On one side, we have malaria. We're trying to reduce the number of mortalities from malaria. On the other side, we have the chemical DDT. It's a double-edged sword. Thank you, Leslie.
Yeah, it is. There many aspects that we have to wrestle with. Thank you so much. Excellent presentation.
Thank you. Thank you, Leslie. And we'll start with Sunny Boy. Sunny Boy, could you share your presentation for the student presentations? And is your mentor here, Sunny Boy, to introduce you? Sunny Boy?
Thanks, Dr. Munyinda. I'm not quite sure if she is around. I was actually looking at the chat. I was looking at the person but I couldn't see her. So I'm not sure if she is around.
Okay. So perhaps you could start sharing your slides while I introduce you. So our next presenter is Sunny Boy Chiko. I hope I'm pronouncing your surname correctly. Sunny Boy is from the University of Johannesburg. He received his MPH from University of Johannesburg in 2023, and he's currently employed in the National Institute for Communicable Diseases as a field coordinator. And Sunny Boy today will be looking at his evaluating schistosomiasis and from the University of Johannesburg, and we're very happy to have you, Sunny Boy. Please go ahead with your presentation.
Thank you. I'm sorry I went over the first slide. Sorry for that. Let me get to the first one. Thank you very much. My name is Sanibo Njiko. I'm from the University of Johannesburg, and my mentor is Ms. Renee van Wyk. I'll be presenting on the evaluation of the prevalence of schistosomiasis among school-age children in low and middle-income communities from Etlhanzeni district. This district is actually based in Mpumalanga, South Africa. We'll be looking at the years 2015 to 2021. The outline is as follows. We'll be looking at the background, the aim of the study, the methods that were employed, data analysis, what results did we find, and how are we going to break the cycle of schistosomiasis. We'll also look at the strengths and suggestions for the future. Nearly 240 million individuals worldwide are infected with schistosomiasis. And this disease is persistent in many low and middle income communities, particularly in rural disadvantaged communities that are in sub-Saharan Africa. In the year 2000, it was estimated that schistosomiasis affects almost 120 million individuals in Africa. South Africa is an upper middle income country, but roughly 5.2 million individuals are thought to be affected with schistosomiasis. And this disease is particularly affecting school-age children. Schistosomiasis is also known as bilharzia, which is an infection caused by a parasitic worm that lives in fresh water, mostly in subtropical and tropical regions. This infection occurs during routine domestic, occupational, agricultural, and recreational activities, which expose individuals to infested water. The disease can lead to hepatomegaly. Hepatomegaly, when we talk about hepatomegaly, we're talking about an enlarged liver, and splenomegaly, which is an enlarged spleen. They can also be affected by anemia, kidney malfunction, stunting in growth, especially children, and reduced ability to learn in school. So with schistosomiasis is divided into two types. We have intestinal schistosomiasis and urogenital schistosomiasis. Intestinal schistosomiasis affect the intestinal tract, and urogenital schistosomiasis would affect the urogenital tract. And these types are actually having subspecies that cause disease. So with intestinal schistosomiasis, we have 4 types. That is for schistosoma manzoni, schistosoma japonicum, schistosoma mekongii, and schistosoma intercalatum. Schistosoma manzoni is mostly in sub-Saharan Africa, the Middle East, and the Caribbean. And then schistosoma japonicum is mostly in China, in Indonesia, and the Philippines. And then schistosoma mekongii and schistosoma intercalatum are mostly in Cambodia and the rainforest of Central Africa. So with schistosoma mekongii and schistosoma intercalatum, they rarely infect human beings. And then the species that cause disease that cause urogenital schistosomia is called schistosoma hematobium, and it is mostly in Africa and the Middle East. In this slide, it shows how a person infected with the disease would normally present. On your left, it's the person who has a distended abdomen that is caused by hepatomegaly. And then on your right, you can also see a person that is presenting with a distended abdomen, which is actually a complication of schistosomiasis. And then the picture in the middle is actually people that are engaging in risky activities. That is when they are swimming on or fishing in water that could be infested with schistosoma. We are actually focusing on the Etlhanzeni district municipality, which is in Mpumalanga province. This province is actually characterized. This district is actually characterized by a high population of people that are living in rural areas. That is about 72%, and the majority of the people living in these communities are lacking access to, say, potable water. There was a study that was done looking at the prevalence of schistosomia between the years 2011 to 2018, which highlighted a concerning schistosomia prevalence in rural settings. If you look on your far right on the map, the darker the color, the higher the prevalence. So the province of Limpopo, Mpumalanga, followed by KwaZulu-Natal, Eastern Cape, and the Western Cape had the highest prevalence. This study aimed to assess the prevalence and identify risk factors for schistosomiasis among school-age children in low and middle-income communities. So these were the methods that were employed. It was a retrospective cross-sectional study that we conducted, and the study participants were children that were aged from 5 to 18 years who had a urine test for schistosoma hematobium ova from 2015 to 2021. And these samples were actually collected in a healthcare facility and were sent to the National Health Laboratory Services for testing. And then the sample size that we were lucky to have our hands on were 24,000 urine samples that we worked on, that were actually examined for schistosoma hematobium ova. And then the data was collected by reviewing secondary laboratory data from the NHLS laboratory services. So for us to get the data, we had to apply for permission from the academic wing of the NHLS, which we were granted, and then we continued with the study. And then in terms of data analysis, the data was analyzed using IBM SPSS version 27. We also had, unfortunately, had duplicated samples that we identified through personal identifiers, and we had to remove those. There were also discordant results, which we had to disregard, and we also had cases that had incomplete data on essential variables that we wanted to look at, but unfortunately, we had to remove those. And then in ensuring that the samples were from Ehlanzeni district, we utilized the laboratory information system of the same company, which is the NHLS, to make sure of that. And then in terms of looking at the risk factors associated with schistosomiasis, we used logistic regression. And then looking at this slide, it shows that we had more males that tested positive for schistosomia at 89%, and 11% of the participants were female who had who tested less on when we enrolled them. And then in terms of age, the 13 to 14-year-old participants had a higher prevalence of schistosomiasis, followed by those that are aged between 15 to 18 years at 25%. And then in terms of sub-district, the city of Mbombela had the highest prevalence, followed by Bushbuckridge at 43%. And then we also had to zoom in terms of the clinics that sent the samples to NHLS for testing. If you look at Mbombela, they had the most cases, and followed by Bushbuckridge, Nkomazi, and Tabatwe. And then this slide is just to reinforce the fact that mostly female children were less likely to be diagnosed with schistosomia, whereas children aged between 10 and 14 years had the higher odds of being diagnosed with the disease. And then how we're going to break the cycle, looking at compounding factors first. In terms of limited education, we feel that educational interventions targeting communities which are at risk of contracting schistosomiasis infection may empower those individuals to develop capacity to minimize the spread of the disease. And then the second point that we wanted to stress was unsanitary conditions. So we feel that provision of clean and safe water and the development of sewage infrastructure, especially in rural areas, this we feel will prevent communities from drinking and swimming in unsafe water. So each and every study has its own strength and its limitations. So the limitations of this study was the strength. I'll start with the strengths. The strengths of the study was where it helped create a baseline for the management of schistosomiasis in the country, especially in the province itself. We feel that it also helped to highlight hotspots in the district, which we feel it will then assist in prevention and management programs. And we feel that it highlighted vulnerable groups as well. And then in terms of limitations, unfortunately, we used secondary data, and this secondary data had some critical variables that had missing data, and then they had to be discarded. And then we would have explored more risk factors, but unfortunately, this was not a quantitative study. We limited us to the information that we have at hand. So what do we think should be, what should we look forward to in future? So we feel that the most crucial element in schistosomiasis control is preventive chemotherapy, accompanied by a full control program focusing on health education for behavior change, safe water and sanitation, environmental management, and snail control. But we feel that we cannot achieve this without political engagement and political involvement and political will. So we feel that we need political will from our governments, because with political commitment, policies on schistosomia control can be drafted and employed. We feel that funding can be made available for schistosomia educational programs, water and sanitation services can be improved, and access to praziquantel can be a reality. So praziquantel is actually a drug that is used, first-line drug that is actually used to treat schistosomia, and has been seen to be effective in that regard. And then our findings and conclusion, we found that there was a high prevalence of schistosomia, as mentioned in the previous slides, in school-age children within low and middle-income communities, especially in rural-dominated areas. Most of the risk factors that we were able to determine were age, and that being a female is a risk factor because we were limited to secondary data, unfortunately. And then we feel that there is a need for an interdisciplinary approach to reduce prevalence of schistosomia in the province and in the country as well. And then tailored health education is also required to be offered to children and parents. This might sound a bit repetitive, but we actually wanted to stress the point that tailored education is required to be offered to children and parents, especially on the signs and symptoms, sources of infection, and contributing factors of its spread. And then we feel that community surveys should be done to investigate other contributing factors around these communities. I would like to acknowledge the National Health Laboratory Services, the NICD, the Mpumalanga Research Ethics Committee. Lastly, I would also like to acknowledge the Practice Cycle Africa team to invite me to present on this platform. I thank you.
Okay. Thank you very, very much, Sunny Boy, for your presentation and for the great work done. I'm sure you can see in the chat there that you've got a lot of commendations on your presentation. So we have a few minutes for some questions. Let me just say, I think there's a question in the chat here from Tija. Are you referring to chemotherapy as in chemical treatment in bodies, as in human bodies, or in water bodies? So there's one question, Sunny Boy. Another one is asking if you know of any studies that involve schistosoma mancini. So can you take those two questions, and then we'll see if we have time for some more questions.
Okay, thank you. I was actually referring to human bodies. One of the strategies by the WHO, and one that is adopted by the South African, that is actually documented on the national strategy of that seeks to eliminate neglected tropical diseases, which schistosomia is part of, talks to mass drug administration to high-risk individuals, whereby they will be using the drug that I was talking about, that is praziquantel, to treat those people. So they were also talking about snail elimination, and I still need to read further on how would you eliminate snails, which is another important environmental factor. And then in terms of studies, there's a lot of studies that are there. If I can mention it, it's just that I did not have them on my slides. There was a study that was done by Juf et al. In the Gambia, which had similar findings as mine. There was one that was done by Mbra et al. From Cote d'Ivoire, who had similar findings as mine. And there's another study by Koulibaly et al. From Cote d'Ivoire as well, who had similar findings as mine. Thank you.
Okay, thank you. Thank you for those answers. Do we have any other questions? Dr. Rubin, do you have any? Yes, please. Teacher, did you want to continue with your question?
Yes. Thank you for answering that question earlier. So if I understand this correctly, so schistosomiasis is a cancer of some sort then, as far as the disease is concerned, or because when you mentioned, the chemotherapy, my understanding of that is like that is only for a cancer patient. So, and yeah, so is it like a cancer then, or if we were to categorize this disease?
I wouldn't say it's some sort of a cancer because it's actually it is how can I put it? I think I'm not. It's actually not some sort of a cancer. It's just that the term that is used is chemotherapy. I do not know why, but the tablet that is used is praziquantel, and it is not listed as a chemotherapy drug. So I do not know why it is termed like that. It's just that I do not have someone who is more qualified, especially in the medical field, who would answer such questions. I think maybe my exposure would limit me to answer, especially the chemotherapy type and the cancer type. But that would need more. That doesn't limit me from educating myself. And I think I owe you an answer on that one. Can I please come back to you the next session tomorrow? Thank you.
Yeah, thank you.
Thanks, teacher. And again, I'm not a clinician. Maybe Dr. Rubin can come in, but I think schisto is a parasitic disease, like he shared earlier on, and it's transmitted with the vectors, the snails and so on. So, whereas again, the clinicians, we can have a discussion after this. Cancer is like a proliferation of cells that are just growing uncontrollably, but we can still have a discussion on that. And after the presentations are shared, I noticed that Sunny Boy did have some slides that talked about the presentation and the manifestation of schisto. So you could have a look at those, and maybe they can shed some more light. And somebody's writing in the chat that it's also known as bilharzia. Yes, growing up, we knew schistosomiasis as bilharzia, but now that we're at university and we're researchers, we're now calling it schistosomiasis. Most of us know it as bilharzia. And before we leave, Sunny Boy, I think, let me just ask this question. The boys and the girls, what really would you attribute the difference that you saw among the boys and the girls? It was quite a marked difference. What would you attribute that to? Just in one sentence, what is the main reason why you saw such differences between the boys and the girls in your results? Thank you.
I actually think that boys, yeah, if you can look at the other slides, the people that were engaging more in risky behavior, like swimming in water that could be infested with schistosomiasis, were mainly boys. So boys are actually known to be risk takers, and most of them are exposed, tend to take risks, and most of their recreational activities are a bit risky. They expose themselves to such water bodies that could be infected with disease. So I think it's mostly about behavior amongst boys and behavior amongst girls. Thank you.
Okay, thank you very much, Sunny Boy. Yes, Dr. Rubin.
Nasiko, I just want to qualify and answer your question that it is a parasite. You're right. It's found in snails and it gets into the water and it can go through the skin and infect people. And the treatment is not the kind of chemotherapy that you would use for cancers is maybe just a chemotherapeutic agent or a chemical that's used to treat parasites. So it's got nothing to do with cancers, although there are some long-term effects of schistosomiasis or bilharzia that can result in long-term illness. Excellent presentation. Thank you, Sunny Boy.
Thank you.
Thank you, Sunny Boy. Thank you very much. And as Sunny Boy is leaving, Goodson, you could start sharing your slides. Unfortunately, you could put it in the chat. Please just type your question in the chat, and I'm sure Sunny Boy can attend to it in the chat.
All right.
Goodson, so we're moving from, no problem. So we're moving from South Africa, we're coming into Zambia, and we're having a presentation from Goodson Shaluvala, who happens to be my student, so I can introduce him. So Goodson is an MPH student, current MPH student who's specializing in environmental health. He has a Bachelor of Science degree in environmental health as well, and is currently a tutor with the Department of Environmental Health at the University of Zambia. And Goodson today will be sharing his proposal. This is a project proposal. He hasn't yet started doing the work on cookstoves technologies and children's safety. And this is looking at indoor air pollution and burns in selected townships of Lusaka, Zambia. Goodson, over to you.
Thank you very much. Good afternoon, good morning, and good evening from whichever part of the world you are from. As I've been introduced by my mentor, Dr. Nosiku Munyinda, I'm Goodson Sharvara, and I'm looking at cookstove technologies and children's safety, a case of indoor air pollution and burns in selected townships of Lusaka, Zambia. So to give us a brief background in terms of what we are looking at, just a moment. All right. So in terms of our background, globally, it has been estimated that over 2.4 billion people use open fires, biomass such as animal dung and crop waste, and as well as coal as their sources for their cooking and eating within their home settings. And this has also been attributed to cause indoor air pollution, which leads to about 2.2 premature deaths. That's in adults, both males and females, and over 237 deaths in children under the ages of 5. And these are mentioned sources of eating and cooking, which includes open fires, the biomass sources, and as well as coal, have also been attributed as major risk factors for burns in the low to middle income countries, where my country, Zambia, also falls under. And within the low to middle income countries, studies that have been done have shown that over 90% of these burns occur in and around the home settings and have been associated with these cooking technologies and have both fatal and non-fatal outcomes. In terms of the non-fatal outcomes, we have prolonged hospitalization for children, a stigma amongst their peers and rejection, and as well as pain and disability. So in order for children to develop this ill health, they are exposed to a combined factors, mostly within their homes, which include absence of proper basic services such as water and sanitation, as well as the usage of solid fuels for their cooking and eating, especially in poorly ventilated homes. So I must also mention that for this particular project, the focus is on the use of solid fuels specifically for cooking technologies within the selected townships within Lusaka, Zambia. And this particular component sits within my main research proposal for my master's level. So in terms of the effects that we see, we look at table 2, the health effects that we see as a result of air pollution. So these are just a few examples of the pollutants that we get to see from the usage of different sources of cooking fuel. So we have carbon monoxide, which leads to exacerbation of asthma, which is a respiratory condition. We have nausea, and in worst cases, we have death. And in cases of nitrogen dioxide, we have worsening of respiratory symptoms as well as the lung functions. In cases of sulfur dioxide, we have skin irritation. Then we also have low birth weight in children that are born. And then also have issues to do with corneal burns or conjunctivitis, which affects the eyes of children. And then for particulate matter 2.5 and particulate matter 10, which is PM 2.5 and PM 10, we have effects that include exacerbation of asthma and other respiratory symptoms. And an example of polycyclic aromatic hydrocarbons, we have naphthalene, which also is associated with low birth weight, premature delivery, heart malformations in children, low IQ, and as well as contributes to DNA damage. And on the other side, we have a table which has air quality guidelines. And I must also bring to our attention that for my country, Zambia, we don't have such guidelines that talk about indoor air pollution. So we'll rely on the WHO recommended standards. So those are just a few examples that include carbon monoxide, nitrogen dioxide, sulfur dioxide, and naphthalene. So in terms of how these children are exposed to indoor air pollution and burns within their homes, so there's a pictorial representation. So the first one, this side, so we have a mother who is trying to prepare a meal for their family and carrying their child on their back. So this is mostly what happens within the low to middle income countries or depending on culture. And also in my country, we tend to see these practices. So children will spend their time with their mothers, and as a result, during their cooking times, they're also exposed to these harmful substances, whether they're being carried by their mothers or they're in the presence of their parents. Then the second picture shows a mother with her children trying to prepare, and you can see the type of stove that is being used as she prepares her meals, so which is open and also is exposes the children to being burnt within the home setting. So in terms of the objectives that we've set for ourselves, we look to explore the perceptions and the practices towards children's safety in addition to indoor air pollution and burns related to cooking technologies in the selected townships of Lusaka district within Zambia. So specifically in terms of exploring these perceptions, so we have two groups. So we have the clean cook stove users. These include the ones that are using the pellet cook stoves, the gas cook stoves, just to mention a few. And then the second class who have the traditional cook stove users are the ones that are using animal waste, the ones that are using open fires, the ones that are using charcoal for their cooking and eating sources. So specifically, we look to explore perceptions and practices amongst the two groups in relation to children's safety when it comes to indoor air pollution and burns related to these cooking technologies within Lusaka district of Zambia. In terms of the methodology, so in terms of the study design, we use a case study design employing qualitative data collection methods. In terms of analysis, we'll use thematic analysis. So all the recordings will be transcribed and all the transcripts will be read. And from there, we'll develop codes, and the coding structure will inform as to how now we're going to generate the themes as we present our data. And then in terms of sampling techniques, we use a multi-stage sampling, whereby initially we are going to cluster our study participants depending on the townships where they're coming from, which is geographically. So these townships will be identified, and then study participants will be picked from those. And then after they're picked from those, then we'll go at household level. So within these clusters, we pick household level, we'll pick the parents who are using these particular different types of cookstove technologies, whether it's in the clean category or it's in the traditional category. So in terms of data collection techniques, we have in-depth interviews. So within the in-depth interviews, we have these two categories where we have the ones that are using the clean cook stoves, the ones that Edgar mentioned, which involves the biogas, the liquefied petroleum gas stoves, and then also inclusive of those that are using the pellet cook stove. And as well as the ones that are using the traditional cook stoves, these are the ones that will fall under the in-depth interviews. Then for key informants who would like to interview representatives from the local municipalities, who also look at representation within their townships, the councillors for these particular wards where these townships are. Then we also look at interviewing the project implementers, because we have different projects that are being run within the district. So also seek to interview those ones. And then in terms of indoor air quality measurements, which we'll do also use monitoring devices to just get the measurements of the indoor air quality within these particular townships. So to help us do that, we have interview guides, checklists, and the monitoring devices like I've mentioned. So well, we think our project to be able to break the cycle. So at those highlighted 3 points, from residential realities to the environmental factors as well as the health outcomes. So if we go back earlier, so from both sides, from indoor air pollution and as well as the burns. So in terms of health outcomes, so under indoor air pollution, we saw there is low birth weights as some of the effects. We have stillbirths, then also issues to do with low IQ within the children. So we are targeting to break the cycle at that particular juncture. And then in terms of environmental exposures, the indoor air pollution, then also residential realities, we are looking at the aspect of ventilation, the type of cook stoves that they're using. So those are the 3 points that we think our project will be able to break the cycle at. In terms of strengths, so since we're using a qualitative approach, this will help us to generate in-depth information to help us contextualize the children's safety from the parents' experiences and how they go about their life. We'll be able to generate information that will help us contextualize children's safety in relation to burns and indoor air pollution. Since it's a qualitative study design, so one of the limitations is that we can't generalize our findings. So that's like one of the limitations of this particular project. In terms of ethics, so as it stands now, we've had permissions granted from the School Ethics Committee, which is on the break, and then as well as from the National Health Research Authority. Permission has been granted for us to proceed to collect data together with the local municipality, which is Lusaka City Council, because that's where the study will be conducted from. Then issues of privacy, confidentiality will be provided to all our study participants. So even as we interview them, even as we provide the information on them, will be attached to the study participants. And then information sheets will be shared, will be provided to all the study participants so they can provide informed consent to participate in this particular study. And all participants will be provided with the right to withdraw when they are not comfortable to proceed with the study. So in conclusion, like Ada mentioned, we have interventions or programs that have been put in place to help address some of the issues that are there within our communities. So now the question that we need to ask ourselves is, what's happening to these interventions? Because in a laboratory setting, some of them have been proved to address issues to do with indoor air pollution. They're also able to protect the children from some of these effects, even burns. But then what's happening to these interventions? And another thing that we need to consider is children cannot be treated like adults. In terms of size, we are different. So even when it comes to indoor air pollution, going by their size and their metabolic rates, children breathe in more air as compared to adults. And when you look at their day-to-day behaviors, they are more likely to get burns as compared to adults. So this study will help us generate information or an in-depth understanding on the perceptions and practices that generally people have towards children's safety in relation to indoor air pollution and burns, and also help us to come up with interventions that can break the cycle at the aforementioned points. So in terms of acknowledgements, I'd like to acknowledge the Break the Cycle Africa faculty, my mentor, Dr. Mnyenda, and my supervisor from school, Professor Zulu, my friends and family, and God Almighty for the strength to be where we are today. Thank you very much. We'll take questions.
Okay. Thank you. Thank you very much, Goodson. And without further ado, we have a question in the chat from Dr. Lange, from Samantha, and she's asking if you think cultural practices will influence the practices and perceptions. That's the first question. Whether cultural practices will influence the practices and perceptions. And another question is asking if you think that the cost of fuel influences the choice of fuel type. So we have those two questions in the chat for you, Gutson.
All right, thank you very much. So cultural practices. So from the literature which I've gathered so far, so cultural practices, yes, they may influence some of the practices in terms of the cooking, because certain literature has shown that depending on the society where women are supposed to be the ones that do the cooking, the cleaning, and all those things, and children are supposed spend most of their time with their mothers, because mothers are supposed to take care of these children, because the father has to go out and to look for the general like food and provide shelter and all those things. So in my line of thought, yes, there's a possibility that cultural practices may have an influence on the practices towards children's safety. And then secondly, the question of cost of fuel influencing the fuel choices. Yes, some literature has shown that the cost of fuel really influences that, but we'll see when we get in the field if it has a bigger bearing on if the cost of fuel has the impact on which fuel type they're using within these selected homes. But literature has shown that yes, this has an impact or influences the fuel choices that people tend to make. And mostly people would pick the cheaper one in terms of their costs.
Okay, thank you very much, Goodson. We'll take the last two questions before we break off for our body break. So very quickly, Goodson, there are two questions in the chat. What is the problem magnitude and consequences in the study setting? I think they're trying to find out why did you choose that study setting? And then there's a suggestion that it would be interesting for you to look at matters relating to indoor air quality at childcare centers, especially those using kerosene heaters in poor ventilated centers and facilities during winter time, because the children spend longer periods in those centers. So that is a suggestion. The second one is a suggestion. And the first one is a question on the magnitude of the problem within the study setting. If you can just quickly, within a sentence, Goodson, answer that. Thank you.
Sorry, ma'am, if you can come again on the question.
So the first question is asking, what is the magnitude of the problem? What is the magnitude and problem in the study setting? And the second one is a suggestion that maybe you could also look at indoor air quality at child centers, like nursery schools, especially those using kerosene heaters in poorly ventilated centers or facilities during winter time.
All right. Right. So for the suggestion, thank you very much. It's something that can be considered going forward. So in its current state, I must say that the approval we got from ethics only limits us to do their own settings, but it's something that we'll consider going forward because it's an ongoing project. And in terms of the question, the magnitude of the problem within the study settings. Okay, so I'll start. Okay, I've been taught to just limit it in a sentence. Okay, so currently in our country, we're also experiencing one of the worst load shedding ever. So mostly people resort to different fuel choices, and predominantly we have charcoal and people who are using waste from the maize as their sources of cooking. So that's like one of the issues that we have. And the other thing is people rarely report effects, especially from indoor air pollution within the health centers. So as it stands currently, those are like the two issues. In terms of numbers, like reported cases from the Ministry of Health, we don't have the exact numbers, but these are the two issues that are driving this study within this particular settings. I hope that helps.
Yeah. Thank you very, very much, Goodson, for your presentation. And this is one of the topics, this is one of the projects which we said earlier on is still in formative stage, is at proposal stage, as you've seen. So we're very excited to see what he's going to find in the field, and hopefully he'll be able to join the bigger Break the Cycle team that will be looking at projects, and later on next year we will have the findings. I noticed that there's still some questions in the chat. Goodson, you could answer the questions later on within the chats, but for now we have to break for our short body break. After our break, we still have two very, very interesting presentations. So we're moving to Uganda, where we'll be looking at environmental hazards and undernutrition in children. And then the best for last, we're going to have our keynote presentation on equity, the equity lens. So please, let's take a short break and we'll come back and reconvene at 20 past 2 African time. And I think it's 20 past 20 past 8 American time or Atlanta time. We'll see you soon. Thank you. Good afternoon once again. Welcome back to our second session that's looking at environmental justice and equity. And from cook stoves and children's safety, we move to chemical hazards and nutrition in children. And to give us our next presentation, we have Dr. Onyinyechi Bede Ojimadu. Onyinyechi is your mentor here. Onyinyechi? Okay, so I'll go ahead and introduce Dr. Ojimadu. She's an early career researcher at the School of Allied Health Sciences in Kampala, Uganda, at the International University in Uganda. She has a PhD in chemical pathology. And today, like I said, she'll be talking to us on her project that's looking at the role of co-exposure to biological and chemical hazards in undernutrition among children in sub-Saharan Africa. Over to you, Onyinyechi. Thank you.
Yes, good afternoon, everyone. Can you hear me?
Yes, we can.
Yes.
Yes, we can. Please go ahead.
Yes, good afternoon. You're welcome. I welcome all of you to this presentation. My mentor is here. He was here, Dr. Ori Shorisakwe. And my presentation is on exposure to environmental hazards and children undernutrition. And this is a scoping review. This is the outline. We're going to be looking at the backgrounds, the objectives, the methods I used, the results, then the conclusion and some recommendations. And then we'll look at where the project breaks the cycle. Yes. Undernutrition has been defined as the deficiency or insufficiency in an individual's intake of energy and nutrients needed to maintain good health. And some of the markers that have been used so far to measure undernutrition include stunting, that is the rates, the heights of children, wasting, that is their weight as compared to their heights. Then we have underweight and some micronutrient deficiencies. Now, when we look at the statistical overview of undernutrition globally, we notice that the global prevalence of stunting and wasting, although it has been decreasing in the last few years, we still have about 31% prevalence of stunting and wasting among children under 5 years of age. And nearly half of these deaths among children under 5 years of age has been linked to undernutrition. And most of these deaths occur in developing countries and what we can call low-income countries. And we ask ourselves, what are the risk factors for this undernutrition? Some of the identified risk factors for undernutrition have included poverty, lack of access to food and balanced diet, inadequate nutrient intake, malabsorption, and excess or excessive loss of nutrients. We also have exposure. Many recent studies also indicate that exposure to environmental chemicals and biological hazards are implicated in undernutrition. So let's look at what do we really mean by environmental hazards. Environmental hazards refer to extreme events or substances in human environments that may cause adverse health effects or health consequences for children, for humans, and things they value. Environmental hazards have been grouped. We have the physical hazards, which include the natural disasters, radiation. We also have the chemical hazards, which include the chemicals around us, in the air, in water, the toxic waste, the pesticides, heavy metals, and other chemicals around. We also have biological hazards, which include the bacteria, the fungi, the helminths, and some protozoa, which we also encounter in our environment. Now, humans are exposed to these environmental hazards, and these hazards have been associated with undernutrition, according to many studies we have around. And exposure to these hazards, we know, occurs simultaneously. That is to say, a human being is exposed not just to one environmental hazard, but we see somebody getting exposed to different hazards at a time. And we are of the opinion that these hazards may interact with each other. For example, it may not just be only the effect of malaria parasites. Somebody that is exposed to a malaria parasite and also exposed to lead, the effect may be more than someone who is exposed to just one of the hazards alone. But even at this, the evidence on individual or combined effects of this co-exposure to these hazards on childhood undernutrition have remained fragmented. And so this review, we aimed to identify these environmental hazards and how they are associated with childhood undernutrition markers. We also aimed to know or provide evidence on any interactive effects of combined exposure to these environmental hazards on childhood nutrition. We searched two databases, PubMed and Scopus databases. And we searched from January 2014 to March 2024. And the preferred, the PRISMA guideline for scoping reviews was followed to examine the available literature on the effects of exposure to chemicals and biological hazards on undernutrition in children. So we use these following terms related to malnutrition, terms related to childhood, and that related to exposure to chemicals and biological hazards. Then we concentrated on children under 5 years of age. For the exposure, we concentrated on different biological and chemical hazards, as I described in the few slides past. Then on the outcome, we looked at undernutrition indices, including stunting, underweight, wasting, and some micronutrient deficiencies. Then we included case control studies, cohort studies, cross-sectional studies, and randomized controlled trials. In our results, from the two databases, we gathered 5,170 studies. And out of these, we did 3 steps of screening, and we finalized with 131 articles. And of these 131 articles, 67 of them addressed the effects of chemical hazards on childhood undernutrition. Then 58 of them addressed the effects of biological hazards on childhood undernutrition, while only 6 addressed the effects of combined exposure to 2 different hazards on childhood undernutrition. Then from our results, we found out that exposure to metals, particularly lead and cadmium, were associated with impaired growth, that is stunting, in children. We also found out that in utero life is an important exposure window to environmental chemicals. That is to say, most of the stunting we observed, most of the children that are being stunted were exposed to these chemicals while they were in the uterus. Another important observation we made from the studies is that exposure to air pollution, particularly particulate matter less than 2.5 and carbon monoxide, were associated with higher risk of stunting as well as anemia. We also found out that very few studies addressed the role of chemical exposure in African children. Most of the studies were from Asia and America. Very few studies addressed these exposures in African children. We also found out that exposure to what we call aflatoxins, that is toxins from fungi, they were associated with impaired growth in children, especially African children. Then we also found out that in these African children, malaria and helminth infections were associated with wasting and anemia. Then for the studies that assessed co-exposure to combined hazards, we found out that co-exposure to malaria and helminths resulted in higher risk of anemia. Also, zinc deficiency interacted with parasitic infections, resulting in an increased risk of anemia among children. That is to say, the risk of anemia was higher in children with both zinc deficiency and parasitic infections. We also found out, and in another study, that lead exposure in conjunction with malaria, lead exposure affected the anemia in children with lead exposure was higher in people with higher risk, higher density of malaria. Another observation we made was that very few studies, like I said before, examined the effects of combined exposure to environmental hazards on childhood undernutrition. Then as conclusion, we have concluded that exposure to environmental chemicals is associated with higher risk of childhood stunting. And we also have concluded that these adverse effects of prenatal exposure to these chemicals are not limited to fetal growth alone, but may also follow up these children into early childhood. Then exposure to malaria and helminth infections are implicated as risk factors to anemia and wasting, particularly among children living in sub-Saharan Africa and Asia. Despite the possibility of interaction within and across chemical and biological hazards, studies examining the effects of co-exposure to these hazards on childhood undernutrition have remained scarce. And because of this, we have made some of these recommendations that more studies are needed to characterize the nutritional impacts of exposure to metals among African children. We also recommend that studies are needed to determine the impact of exposure to mixture of chemical hazards on childhood nutrition, because these children are not exposed to either one chemical or one biological hazard alone. They are exposed to a mixture. But we found out that very few studies have examined the effects of this mixture of hazards. So we are recommending that more studies, especially from Africa, be made to determine the impact of this co-exposure on childhood undernutrition. Then on combating childhood undernutrition, we have, because of our risk discovery that environmental pollution is a significant risk factor for undernutrition. Combating child undernutrition requires multifaceted approach, not only trying to recommend of food and nutrition security, but also environmental pollution must be looked into, because nutrition campaign alone cannot combat undernutrition globally. A lot of things, a lot of work, a lot of strategies has to be put in place to combat environmental pollution in order to reduce the prevalence of childhood undernutrition globally. Now, how this project breaks the cycle, from what we have said so far, it is evident that this study has established a link between environmental pollution, environmental hazards, and nutrition. And so measures aimed at reducing exposure to environmental and biological chemical hazards would reduce the level of childhood undernutrition and the associated mortality. So this project breaks the cycle at these 2 points, because reduction in environmental hazards, exposure to environmental hazards, will go a long way reducing the prevalence of malnutrition and associated mortality among children globally. These are some of the references we used. And I would like to use this opportunity to thank the BTC African team for giving us this great opportunity to showcase our studies. I would also like to thank my mentor, Professor Orisho Risakwe, for his guidance and his contributions in this study. I would also like to acknowledge my collaborators, Dr. Shiara Frazzoli, Dr. China Orish, Beatrice Boka, Beatrice Battistini, Flavia Rogeri, Dr. Samuel Ofo, Anthony Owa, and Jesse Indem for their role in preparation of this study. So thank you everyone for listening. Thank you.
Thank you so much. Thank you so much, Onyinyechi, for that very, very interesting presentation. Interesting and a bit worrying for me, for me at least, because all the factors that you've talked about, I'm sure even from previous presentations, we do have a very high, we talked about malaria prevalence. Now you talked about undernutrition and also these chemical exposures and how they are all interacting in these children's bodies and what we are ending up seeing on wasting. Professor Rubin, Dr. Rubin, you've said something in the chat. Would you like to say something to Onyinyechi?
Yes, I really do. I think, Onyinyechi, what you've done is you've captured the realities of cumulative impact as you saw in one of my earlier slides, I showed that for poor kids, there are many factors that adversely affect their growth, health, and development. And in the US situation, what you've done is you've shown us how that plays out in the African situation in terms of the chronic issue of undernutrition and the impact of all the other environmental factors, chemical, insect vectors, water, and everything. So I really like that. And I just want to make this first public announcement that we've had 19 annual Break the Cycle programs, and we're about to enter our 20th year. And the theme of this year, this coming year, is cumulative impact. So I think you've just kind of helped to launch next year's Break the Cycle program. And please continue your work, and hopefully we can have you present at that, or have a project that will be part of that conference.
Thank you, Dr. Rubin. And
thank you, sir.
Just to underscore the need, Onyinyechi, I'm not sure whether you've actually published your work, because I can say that in Zambia, for example, we have one student who published on undernutrition and environmental factors, but he was looking at water and sanitation. He's actually present in this conference. But we've also done quite a bit of work on lead, and we did find that lead also exposure to lead and blood lead levels contributed to stunting. And it's interesting that you've also found a similar relationship, and also to HB. So that also just shows the need to publish our work. And it's good that through this platform, we have the opportunity to publish some of our work, and therefore we can include these kind of publications in scoping reviews like the one that you've done. And I also like the fact that you use the scoping review. You are not collecting primary data. So hopefully the other students can see the value of different research methods as well. So thank you once again, Onyinyechi. There are a lot of compliments in the chat. You can have a look at them later on. Thank you.
Thank you very much.
So thank you. And so we come to the climax of our day. We have our keynote address from Dr. Onyinyechi Nwaka. I hope I've pronounced that correctly. Very similar names with our previous speaker. And Dr. Nwaka has more than 20 years experience in the Office of Environmental Justice and External Human Civil Rights in the U.S. Environmental Protection Agency. And we're very honored to have her at this conference today. And she'll be talking to us and presenting on the equity lens and its implications on environmental health, research, and practice. So Dr. Nwaka, we're very glad that you agreed to be one of our keynote presenters, and we are looking forward to your presentation. I hand over to you. Thank you.
Thank you. So I have a quick question. I guess I have to, okay, I can share my screen now. I couldn't initially. So hold on a second. Right. And then there we go. So let me start by saying greetings, everyone, and say thank you to Dr. Leslie Rubin, the organizing team, and everyone who has put in a lot of effort, the presenters, the organizers, for hosting a Break the Cycle of Children's Environmental Health Disparities in Africa Conference. It would not be possible without all of you, and it's really very important and so timely. So I work in environmental justice, which is all about environmental health disparities or inequities. And I also work in the policymaking space at the federal level in the United States. My work is majorly about ensuring that our federal policies, especially environmental policies, consider environmental health inequities, and that our policies are designed to prevent new, mitigate existing inequities in environmental health. So we cannot get our work done without the equity lens on research and practice. And that's kind of the gist of what I want to share with you today. Sorry, let me turn on my clock so I don't go over. So the goal today is to share from a policy practitioner perspective, the different ways in which your research as disparities research practitioners supports policymaking. And I'm leaning on our experience in the United States. And the idea here is to encourage up and coming, as well as, veteran research practitioners in the audience by sharing some of the monumental gains driven by your kind of research. So before I dive deeper into my presentation, I want to just issue a traditional disclaimer, which we always have to do, which is that this is not an endorsement from the EPA, whatever I say, and I'm going to be speaking about our work experience, but this is just a standard disclaimer we have to issue. So we're going to do some definitions. It's important to share definitions for the equity lens and environmental health inequities, because there are so many definitions out there, especially in the last couple of years, there's been this vibrant expansion of the field of practice. And so there are lots of definitions, but I want to make sure that as I speak, we all have a harmonized way of, hearing me and taking in the information that I'm providing. So I'm going to use both of these terms quite a bit. So the equity lens, which is from all the presentations today, this is what you're already doing. And it's used in children's environmental health disparities research, is the lens through which we view conditions and circumstances to have an understanding of who is experiencing the benefits and the burdens of policies, programs, practices, procedures, and the basis, the whys for those differential experiences. Environmental health inequities, on the other hand, it's not the opposite thing, but to define it, these are differences in environmental conditions and health outcomes or related health outcomes that are socially driven. They're socially driven. So what this means is that these inequities exist as a function of social structures and identities in society that are linked to the distribution of power, prestige, privilege, influence, resources, and ultimately access to the environmental conditions that either support or degrade health. So there are between social group differences, and these differences, these between social group differences and environmental exposure and health outcomes are avoidable. If they're man-made, if they're made by decisions, practices, then they're man-made. So they're avoidable, and they're also remediable where they exist. And this is why we call them or refer to them as unjust. And it's partly why in the field of practice of environmental justice, we call them environmental injustices as well. So in most parts of the world, the social hierarchies are based on, sorry, it's my phone. I am so sorry. So in most parts of the world, social hierarchies are based on education, income, occupation, tribal affiliation, and race and ethnicity constructs. So over the next several slides, I'm going to highlight the type of value that your work brings to policymaking tables. And I'm trying to give you insights into what we value, how we use your data, and the kinds of questions that your data triggers when we receive that data. I will also share examples of institutional and policy changes that have occurred because of the type of research that you do in the United States. So the equity lens in research is the reason why we know that there are important social differences in environmental exposure and environmental health risks, and the reasons why these differences exist in the first place and the reason why they persist. So here are some examples. This is data from the study of how disparities in particulate matter measuring 2.5 micrometers in diameter or less have changed over a 16-year period. So on the left graph, you can see that there is a significant success. There's a significant decline over time. So it's a great success story to be told. We have a 40% reduction in the population-weighted average annual PM 2.5 concentration. Now, however, when the equity lens was applied in this same research, you see what happens on the graph to the right. You begin to see how these benefits and reductions have been experienced across racial groups. And what you learn from that is that inequities reduced overall. So you can see that at the beginning of the time period, you do have a wider gap, and then everybody experiences a decline, but you still have gaps. You still have those racial gaps. So just to give you an example of how wide the gaps are, in 2016, the researchers estimated that the annual average concentration for Blacks was 14% higher than the white population. Still on the issue of particulate matter 2.5 exposure, this is a graphic that was actually published published within the Guardian News of London in 2023. It shows that as the percentage of people of color within the geographic unit we refer to in the United States as the census tract increased, the median ambient concentration of particulate matter 2.5 increased as well. So what you see here is as you go from the left side of the graph, to go from here to there, what you're seeing is an increase in the percentage of people of color who live within this geographic unit known as the census tract. And it doesn't make sense biologically for PM 2.5 concentrations to increase as the percentage of the people of color increases. And that's why everything we do is about social differences. These are man-made differences. So here is one more example of the application of the equity lens using occupational exposure. So it's a study of cumulative phthalate exposure in Vietnamese American nail salon workers. And what it shows here is, what we show in this data is that there's a geometric mean cumulative phthalate daily intake in this population of nail salon workers, Vietnamese American nail salon workers, that is 97% higher than in the larger population of Asian Americans. So the exposure here is driven by what is happening in the occupational setting. And these data indicates to us that there are exposure sources beyond general consumer products. So phthalates is something that is a plasticide, it's a class of plasticizer compounds, and phthalates are found in furniture, consumer products like food containers and so on. But what we see or what we learn from this data is that not everybody is getting exposure from the same sources, and that for some groups in the population, their sources of exposure actually yield more exposure to the hazard that we're trying to regulate. So how do we factor this knowledge into our decision-making processes? It's something that we have to constantly think about. Data like this has driven the ask for the use of aggregate and cumulative risk assessment methods, and even cumulative impacts assessments, which I'll kind of refer to briefly later in environmental policy making. So the equity lens is also a great tool and a process for uncovering root causes and policy interactions, because it is both a process and a tool. As a process, it causes us to think about the impact of the design and implementation of policies and practices on marginalized groups in any society. As a tool, it is used to identify who's doing well and who is not doing well, and then to also pinpoint the responsible systemic barriers. So in the last couple of years, we have seen the emergence of research using the equity lens. I wouldn't even say the emergence, I would say growth, rapid growth in research using the equity lens that shows the interactions between federal housing and lending policies in the United States, local land use zoning policies in our local government divisions, and then environmental policies to create these heavily burdened communities of color. So let me explain this a little bit, because this is a part of history that's very unique to the American context. So in the 1930s, a government-backed corporation known as the Homeowners Loan Corporation was created to help refinance home mortgages. So in the United States, people rely on loans to buy their homes, and that's what we're calling home mortgages, and expand access to affordable home loans. So what they did back then in the 30s is they created a discriminatory map called a residential security map, which is what you're looking at on the screen. And this map graded communities from like A through D. And A represented the best areas with minimal risk to lenders. So if you're a bank and you're lending home mortgages, when you see that somebody's trying to buy a house in an area graded A, that's a good decision for you to give that person the loan. Areas given a D grade were colored in red. Historical records indicate that the grading was based on factors such as the concentration of undesirables. So this is a reference to the kind of people that tended to live in areas graded as D. And this referred to low-income families, Black and Oriental families, and immigrants. So people of color were directed to buy homes in areas graded as D. And these areas, the importance of this is it was a decision made in the, should I say, banking sector, right? And these decisions, these areas became easy targets because it concentrated a certain kind of people in certain geographic areas. And so these areas became easy targets for government disinvestment and placement of commercial and industrial development. So today, we can see from this example that these D-grade communities now tend to bear the highest environmental exposures. In this 2022 analysis, the researchers found a practically linear correlation between the grading of an area in the historical redlining maps and population-weighted nitrogen dioxide levels in 2010. So this is over eight decades later. So you can see that the effects of redlining still persist. You can see that gradation there. So armed with this knowledge, researchers and environmental justice policy practitioners have, well, environmental justice scientists in the community. So we rely heavily on information provided by our community scientists. They have increased their call for new decision-making strategies and frameworks that account for cumulative environmental disadvantage. And Dr. Rubin alluded to this just before I started talking, based on the presentation from Onyinyechi. So, and also to focus on actively seeking out and addressing policy interactions. So we can't just be creating policies in our different silos in government and assume that we might mean well. In this case, the homeowners, the mortgage industry didn't have great plans when they came up with the redlining map. But for the most part, a lot of government agencies are making decisions to improve the well-being and health of their people. But if we don't think about the ways that our policies interact, sometimes, and it is a known thing in the policymaking arena, that policies can have unintended adverse consequences, as well as unintended benefits. So it's important that we pay attention and do the analysis and invest the amount of thought into the development of policies to make sure that we're not creating adversity in communities. So this kind of research is really changing the way that we think and do business to protect environmental health. So today, not surprisingly, these redlined areas continue to be some of the most environmentally disadvantaged and socially vulnerable areas with regards to poverty, low educational attainment, unemployment, poor housing quality, and so on. So this is a map from Philadelphia. And you can see in this map that what you're seeing on this side is, on the left-hand side, the old map. What you're seeing here in these red areas are the red-lined areas. And what this research group has done is they have actually used what is known as a social vulnerability index that was created by the CDC to create this map on the right-hand side. And what you see is from the top to bottom is a score for social vulnerability. The higher the score, the higher the level of social vulnerability in the geographic area. And you can see, if you just look at this little piece over here, this area that looks like it's jutting out of the map, you can still see that, oops, I have to go back. Yeah, you can see that there's alignment. There's alignment with this area, which was redlined. And you can also see some of that happening in this area as well, which is pretty much a lot of this area. And in some instances, when you see improvements, not always, it's because an area has been gentrified. And what that means is they've developed it. And, with that development has come an exodus of the original residents. And you have new, wealthier people of a different race coming into the community, not because it's racially motivated this time, but because they are the ones that have access to the resources to pay for the homes in those areas. So what have decades of environmental justice or environmental health disparities or inequities research changed in the United States? What is different? So without doubt, there's a lot of work that needs to be done. We've barely scratched the surface, but we've also made a lot of progress to address these injustices. However, we would not be where we are today if not for those researchers who stayed the course and dug in. You know, someone once told me environmental health disparities research was a hard sell to funders. It's not the same way anymore. And that's because the work of this community of researchers and the larger disparities community has shown that these are real issues and obstacles to attaining population health and well-being nationally. So in the next couple of slides, what I'll do is I'll show you some of the seminal institutional and policy changes that have been brought about by research from the environmental health communities of practice. Institutional change is a big one. So because of the knowledge gained from studies and research to demonstrate that these inequities and their drivers are real, the Office of Environmental Equity was created in 1992. And this will later become the Office of Environmental Justice in 1994. And 30 years later, in 2022, the office was expanded in staff strength. We went from like 25, 30 staff to 200. We also became a national program. So we're now the Office of Environmental Justice and External Civil Rights. And this is because people have made the case. People stayed on it, kept producing the research, kept showing the disparities or inequities. And so they made the case for the government that this is a big issue. And what this new configuration that we have has done is it has given us a seat at policymaking tables within the agency. So in the agency, like for example, we do regulatory development. And when we do regulatory development, each of the main, we call them assistant administratorships. So these are the major administrative bodies within the agency. We have the Office of Air, that's one of them. We have the Office of Water, that's another one. Our office is now at that level. And what that means is when any regulation or major policy is passing through the agency, we have a vote. We can speak to it, we can request changes to the policy. And we're doing that while using the equity lens. It also gives us a very strong position at tables where analyses are being done and where policy options are being selected. So that's significant because I heard earlier in some of the presentations, people talking about we need to engage policymakers. Engaging policymakers has levels to it. There's the one where you can just let a policymaker know that something is not working. But then there's a level where you have a seat at the table and you can request changes and you will be listened to. So on the right side of the slide, much of the early research and advocacy was a collaboration between a few niche researchers and community experts who were bringing their lived experience and knowledge of the political, social, and cultural context of their communities to the table. And they were doing this to educate policymakers and advocates for change. Well, shortly after the creation of the Office of Environmental Equity, the administrator at the time, Carol Browner, this was in 1993, created an advisory committee, which is representative of the key stakeholders in environmental justice, known as the National Environmental Justice Advisory Committee. We call it the NEJAC for short, NEJAC. So this is by design a conduit to community voices and a source of critical input, vital input on environmental justice issues, the context within which these inequities are happening, and the opportunities for effective policy action. I cannot sit in my desk or at my desk in Washington, D.C. and possibly know what's happening in somebody's community, several thousand miles away. We need to have them at the table so that they can share those very vital pieces of information with us. Historically, it was a norm that only academic researchers could qualify for federal funds to do research. Having experienced the value of community-driven research and the critical role of community-based organizations in driving the conversation and knowledge creation about environmental inequities, EPA created a small environmental justice grants program to support these organizations' work. Nobody was funding them. And so since then, we now have several grant programs providing, at least as of this year, over $3 billion in funding and technical assistance to communities. And some of this funding is going to air monitoring, is going into community change programs. And a lot of that is on our website. On the graphic to the right, Prior to 1994, there was no explicit policy mandate to address these inequities. So President Bill Clinton issued the first executive order on environmental justice to focus attention on environmental and health issues affecting communities of color. And that's Executive Order 12898. One of the things this executive order did, it was the first one to recognize the need for all the federal agencies to sit at the same table discussing the very issue of environmental injustice and how, through doing what they do best, how they can contribute to addressing environmental injustice. And we all know from the conversations today or presentations today and the discussions we've had why this cross-sector collaboration is really important. About 30 years later, with the growth in knowledge from research, using the equity lens, we now have several executive orders. I think we have about 6 or 7 from this administration, and even sections of laws, such as the Inflation Reduction Act, all focused on environmental justice. The executive orders direct and support the work of the federal sector beyond EPA to expand, strengthen, institutionalize the use of the equity lens to achieve environmental justice. 14091 is the reason why every federal agency now, in every federal agency in the United States now has an equity action plan. Every federal agency. That was a dream actually 7-8 years ago, that was a dream. Today, every federal agency has that. 14096 is a reinforcement and an expansion of Executive Order 12898. And so it takes into consideration all that we've learned between 12898 and 14096 and continues to emphasize the need for all federal agencies to be at the table and for us to identify and address those disproportionate environmental exposures and risks that are associated with environmental injustice. So in conclusion, your research is the underpinning of policy. Your research matters. So what would I suggest to you to consider for how to grow your children's environmental health disparities research and its impact in your country and even perhaps globally? So the first thing I would say is find out what is happening in the policy arena with regards to your research interests by interacting with policy practitioners. That has been one of the best things to happen to our agency and policy practitioners like us. In some of the presentations today, I actually heard about the need for policy. I think it was a presentation on schistosomiasis of Bill Harzia. I could not agree more. With environmental justice issues, it's quite typical for the researchers to be the ones to draw attention to a problem or the need to do more about a problem. There are also many questions to ask, such as, are the policies being implemented? It's one thing to roll out policies, another thing for the policy to be implemented. Then it's another issue for the policy to be implemented right. And these are questions that researchers can ask by prodding the effectiveness of policy using research tools available to you. Are sources, exposure levels, associated disease risk changing following the implementation of these policies? And these are the types of information that help us know we need to do more or we need to do things differently. Ask your policy practitioners what data they do not have. What type of knowledge is presenting a barrier to doing more? And if there are policy practitioners in the audience, I ask you to reciprocate. So right now, I am currently in the process of concluding an activity where we brought together our agency's risk assessors to ask them about the challenges they face when accounting for social vulnerability in their risk assessments, and to know what types of data and methods they think would be helpful. They served up quite a lot of information that we will share with the scientific community over the next year or two. So if they don't have a forum, excuse me, for you to meet with them regularly, maybe this is something you or your university and partners can organize. Engage community voices in your research. As equity partners, you need to understand the social, cultural, and economic context of their exposures. You already know that. I saw that from the presentations today. Very important. Otherwise, we're just putting a Band-Aid on a gaping, on a gangrene type of wound. Explore root causes and policy interactions. Policy interactions are so critical. And interactions are happening across all levels of policymaking, whether it's national, state, local. So it's important. And the root causes, so that you know the right tools to bring to the table. Question traditional scientific and risk assessment assumptions about the relationship between chemical stress or exposure and disease. I didn't have enough time, but the social determinants of health, what we call social vulnerability, that is so critical. Psychosocial stress, poverty, unsafe or public safety issues, food deserts, not having access to healthcare. These are the things that drive, that contributes to create these environmentally disadvantaged communities. So use the equity lens to dig deeper, collaborate with other disciplines. Our work is cross-disciplinary. We're not going to be able to do it alone as environmental health scientists. We need geographers, political scientists, social scientists of all kinds. So let's do that. Connect with researchers globally, which is why I was so excited when Dr. Rubin said he was going to do this. I'm really thrilled that this has started, and I hope this is the beginning of something that's going to last for forever. So new methods are evolving, new ideas and knowledge are being produced regularly by you and those across the different ponds. Let's rub our heads together to strengthen research policy, research and policy to eliminate these disparities. So I really hope that this forum can be one such place where this type of interaction takes root. So much gratitude to the researchers and advocates who make the work of policy practitioners doable and who propel us in the right direction with knowledge. Stay encouraged. Your work matters. And thank you very much for the opportunity to do this keynote address. Thank you.
Wow. Yeah. Thank you very much. That was an amazing way to end the day. It's good to know that our work matters, and we need to continue asking the questions, to continue knocking on the doors of policymakers, and to be able to answer the questions that policymakers may have. And it's just so amazing to see the amount of work that you've been doing at the EPA across the US. I know how big the US is, and you're managing to collaborate and to coordinate all that work across the federal agencies. That's really commendable. Thank you very much, Dr. Nweke, for your keynote address and your encouragement. Thank you. Thank you very much. There are a number of, thank you. Yeah, we do have some views in the chat. So we have a question. Somebody's asking how to locate policy practitioners associated with the EPA in the US. So just trying to find, how do you get the policy practitioners that work with the EPA in the US? I'm not sure, Vuma, the name is a bit, whether you're actually in the US, because you're asking specifically for policymakers in the practitioners in the US that are associated with the EPA. The rest are really just commendations for the great presentation. I think all of us have been really energized. Thank you.
Sure. And do you want me to go ahead and just reply them in the chat? Or
I think you could, we still have a bit of time before we end the day. You could respond to him, and maybe also just help the rest of us or everybody else on how they can actually start approaching policy practitioners in their countries.
Yeah, so let me start with Bidmia's comment. So if you want to locate policy practitioners associated with the EPA, first thing is to go to our website. And well, it depends on the issue. What issue are you interested in? If you're interested in water, air, there's the Office of Air, the Office of Water. And then if it's a children's environmental health issue, we actually have our Office of Children's Health Protection. And if it's an environmental justice issue, we have our Office of Environmental Justice. So we do have a website, it's epa.gov. And on that website, it would walk you through, you'll be able to find the different offices. But I also know that government is like this big brick wall. And when you're looking from the outside in and you're trying to find which door to open, it's like you see 1,000 doors and you don't know which one to open. So I'll drop my email here. And if you need assistance, just call me and we'll find somebody who can speak to you about the issue that is of interest to you. In terms of approaching, I see Leslie's hand. So Leslie, let me answer your question before I go on to.
No, please go on.
Okay.
Yeah, no, my question will still be there.
Okay. So in terms of how to approach policy practitioners, I think the first thing is to define the problem. Once you know the problem that you're trying to address, it becomes easy to figure out, where you need to be interacting with policymakers. So, for example, if you're concerned about, let's say, a polluting entity. Now, I'm going to talk about the U.S. because I'm not aware of the regulatory structure in African countries that are on this call. But in the United States, what we do is, Congress passes a law. In the law, they tell us how to regulate particular types of pollutants or sources. And then we translate that into what is called a regulation. So a regulation is basically a rule that says it's a rule or direction to the regulated entities and to those who are going to be regulating them, because it's not, we have a system where we delegate authority to states, and then local governments also have a role in implementing our rules. So those rules basically tell the regulated entities, which will be like, for example, manufacturing facilities or refineries. It tells them, this is what you need to do in order for this particular type of source, emission source, in order for you to be in compliance, right? And so the permit that has to be written for that particular source is usually written either by the state or it happens in concert with the state and local authorities. So if you're trying to deal with a permit issue, the first thing is to go to the local authority or the state. So you have to figure out where that jurisdiction is. And it's a lot of work for an average person who's living in their home, and they don't want to continue to be exposed to pollution, but they know that it's happening and they want some action taken. But that's the kind of legwork that has to be done. The other thing is actually, going to the federal agency, because federal agencies, I don't want to say they have oversight, but we have access to most of the practitioners that are at the state and local level, and we kind of know how the system is organized. And so if there's a drinking water issue, for example, the first port of call should be, there's something coming out of my taps, I don't like it, can the local government do something? There's usually somebody at that level to do something. But when there's no response or there's an inadequate response at that level, then it's that, they can come to the federal government. They can also start with the federal government, and then we'll figure out who to contact at the local government level. So without having information about how your own government systems are structured, my recommendation is to, first of all, start with, this is what I'm working on. How is this issue addressed? Who normally would work with it? Sometimes people can start with the Department of Health, and the Department of Health will connect the Department of Environment, especially like on an issue like lead. Sometimes it starts with the Department of Health because there's a finding that there's lead poisoning or lead exposure in the community, and then the Department of Health brings in the Department of Environment.
Thank you. And Leslie, before maybe just to answer that question, and for the context of some countries like that could be similar to mine, what I've found for researchers, the easiest way to have an interface with policymakers is to sit on some of the technical committees that are within those ministries, for example. So if, for example, you've done your research and you disseminate it, I would advise that you have kind of dissemination that you target specific policymakers that are in charge of that area that you're looking at. So you might want to disseminate or do a policy brief and disseminate it to that particular ministry. So when they're sitting, and if they have a working group or something like that, they will invite you to sit on that working group. And in that way, then you have your leg in there, and you can find a way of influencing policy. I'm happy to say that the work that we did on DDT, for example, really helped in the country looking for alternatives to DDT, because now we had local evidence and the Ministry of Health had evidence that was Zambian. Before, they were arguing that a lot of the work was done in the US and in Europe. Our population is different, but when we showed them our work, we got their attention that way. So that's another way that you could work with the policymakers, is disseminate your findings and find a way, join a group, join a working group, a committee, and sit there, and in that way you directly give your input into the policies that are being implemented or developed. Dr. Rubin.
Yeah, thank you very much.
Leslie?
Yes, thank you. Thank you, Nosiko, and thank you, Miechi, for, showing us how every little piece of research that we've heard about today can impact major decisions about changing policies and improving the health of everybody. I said in the beginning, like, each one of us is doing a very little thing, and we should continue to do those little things, because each little thing cumulatively adds up to making a big difference. So I also want to thank you so much for not just coming to speak to us today, because I think this has been very meaningful, but for your support and your encouragement and your contributions to this very conference, which are substantial. So thank you. And as you said, Mechi, that this is actually the beginning. This is our first annual conference. So we're going to continue to have many more, and I hope you will continue to be part of them as we go forward. Thank you so much.
Thank you for having me.
Yeah, and I can't add anything more. Thank you so much once again, and we will keep knocking. Some of us from across the oceans, we will keep knocking on your door to even learn more from you. Thank you so much.
I have a quick question. I'm sorry, it just came to mind.
Yes, of course, Leslie.
About the EPA and EPA's reach. Mechi, remind me, is the EPA involved or has counterparts or relates to other countries in a way that influences the policies relating to the environment and environmental justice in particular in other countries?
So I wouldn't say, I don't know about environmental justice specifically. We've had conversations in the past with other countries about environmental justice, but mostly in a learning posture, like what has been your journey, what has been your experience? And that has happened especially with the country of Brazil. But I do want to say we have an Office of International and Tribal Affairs, OITA. It's also on the EPA website. They're very actively involved with UNICEF, WHO, UNEP, United Nations Environment Program, in crafting policies. One policy that comes to mind that is an active issue on their plate is lead. Lead policy, especially about lead in paint. I know there are a couple of countries who still have lead in paint, and that's something that they're working together with in that consortium of stakeholders to address through policy. So Office of International Affairs is one way to do it. Usually they would work on, I've seen where they work on specific issues, such as lead, sometimes air quality. I know that years ago when there was a call or a push to remove lead from gasoline globally, they were also very actively involved in that.
Thanks.
Perfect. Yeah, that's very useful. Thanks for asking that question, Dr. Rubin. I know that from the exposure science side, we use a lot of EPA guidelines for different methods and different things. So it's really good to see that we have an EJ side as well. And this is an area I think that we need to do a lot more on. We have seen, even just from today's presentations, that a lot of issues we're dealing with are disparities, and there is an environmental justice angle that we need to tackle. We need to tackle more, even within our research. So yeah, thank you so much. And thank you, Dr. Rubin, for those questions as well. Thank you.
Thank you.
Okay. Yeah, so I'm seeing you're looking at the chat. So people are asking for your contacts as well, your email address. And there are a few more questions in the chat. Thank you. Thank you. Dr. Rubin, can we go on to close for the day?
Please do, Nosiko.
Okay, thank you. Thank you very much. And Thank you for everybody who's stayed with us throughout today. It's been a loaded day. It's been a marathon, but we've gone through our presentations for today. We've gone through our keynote addresses, very, very interesting and new areas for us to really think about emerging research areas, the heat stress and its resulting impacts on children, on maternal health, and society in general, and now the issue of environmental equity and environmental justice as we continue doing our research, and even more importantly for us to start thinking about how we can influence policy as well as in our different projects. And just sort of a summary, we've had great presentations from researchers as well as practitioners. We had our presentation from Madagascar that looked at emotional abuse, and very, very emotional presentation, but very gratifying to see how the work that you're doing, Francesca, is actually influencing people and helping the young people in your community. So it's very interesting to see how we can turn findings into projects that will break the cycle directly with the communities that we're working with. So today we looked at environmental justice, we looked at environmental exposures, and break the cycle in general. We had a very good presentation from the founder of Break the Cycle, Dr. Rubin, and it's taken 20 years for it to come to Africa. And we're glad that it's in Africa now. And with the encouragement from Dr. Nweke, we'll be doing Break the Cycle Africa forever. We have almost 160 people here, and I'm sure that we can continue breaking the cycle within Africa. So just to finish up for the day, tomorrow, if you allow me, Leslie, to just go into tomorrow's program very, very briefly.
Please do.
Okay, so tomorrow we continue with our presentations. We have very interesting discussions on climate change, food safety. I'm sure you remember from the presentations that we had today that we do have food safety issues within Africa. So we have a whole session that will be looking at food safety. And then in the afternoon, we'll be looking at climate issues to do with climate change. And like I said earlier, we'll have a closing session where we'll put our heads together and we'll have a plenary on the way forward. So please do join us tomorrow for another very enlightening day of presentations, of sharing of knowledge and experiences. And more importantly, we plan the way forward tomorrow. So I would really encourage us to come back together tomorrow, 10 hours, same time, 10 hours African time. I don't want to say the time in Atlanta, but 4 o'clock Atlanta time. Let's come together tomorrow and continue with our conference and plan the way forward. Thank you very much for everybody who stayed with us today. To our keynote presenters, once again, thank you. Our students, thank you so much. Your mentors, we wouldn't be here without their mentorship. And of course, behind the scenes, Jimena and everybody else, thank you so much. And we'll see you again tomorrow. Thank you.